This is Samantha.
Anybody else? So let me just say that one more time. I think we're about ready to get started. On the phone, I have Denise for Jorge and for Molina, Ruben, Lori, Madeline, Dan, Ed.
This is Samantha Frederick from Quality Behavioral Health.
Samantha?
Samantha Frederick.
Great, thank you.
Samantha Zimmerman, is that who it is?
No,
Frederick.
Samantha from Quality Behavioral Health.
Anybody else on the phone? Okay. Well, I think we can officially, I think we've got a quorum, right?
Yes, we do.
Okay. So let's go ahead and call the meeting to order. Happy Thanksgiving, everyone. Let's go ahead and start with introductions, and we'll go ahead and start with the folks on the phone. So I'll just call your names. That way we don't have to hopefully talk over each other, and then you can introduce yourself. So let's start with Ruben.
Ruben, City of Pasco.
Lori?
Lori Brown, Southeast Washington, Aging and Long-Term Care, representing social services.
Madeline?
Madeline Carlson, People for People, representing transportation.
Dan?
And Dan Ferguson with the Allied Health Center of Excellence with the Community College System, representing workforce.
Ed?
Ed Thornbrew, Comprehensive Healthcare, representing behavioral health.
Denise?
Denise Wong calling from Molina Healthcare on behalf of Jorge, representing MCOs.
Slide down a little bit. Whoever's running it. I just missed something.
Sorry, I'm not.
Okay. Samantha. It's just fucking me out. Samantha, would you like to introduce yourself?
I'm Samantha Frederick from Quality Behavioral Health.
Okay, thank you very much. Is there anyone else on the phone that I missed? Okay, so let's start in the room, and why don't we start with Les and introduce yourself and organization and sector after the macaroni and cheese goes there.
I'm Les Stallmacher from Educational Service District 123, and I work with education.
I'm Lauren Johnson. I'm with Greater Columbia ACH.
Rhonda Hoff, Yakima Neighborhood Health Services and Chair of the Board.
Darlene Darnell, Catholic Charities, community-based and faith-based organization.
Sarah Foster from Astoria Sunnyside Hospital.
Diane Haler from Greater Columbia ACH.
Patrick Jones from Eastern's Institute for Public Policy and Economics.
Pat Lefay, Community Health Plan of Washington, attending as a guest.
Ruben Peralta, Greater Columbia ACH.
Ronnie Batchelor, Lisbon Community Services, transitioning to Lourdes Crisis Services as of December the 5th, and I represent the consumer.
Wes Lucky, Greater Columbia.
Becky Colton, Greater Columbia. And Victoria, Yakima Valley Farmers Clinic, representing SUHC.
Julie Peterson from Kittitas Valley Healthcare. I represent hospitals.
Ashleen Fernandez, Greater Columbia ACH.
Carol Moser, Greater Columbia ACH.
Martin Sanchez, Greater Columbia ACH.
Jenna Shelton, Greater Columbia ACH.
Martha Engels, Coordinated Care, also a guest.
Barbara Mead with Lord. Barb, we have room up here. Why don't you join us at the table? Okay. So, Kat, I have forgotten. Who's the MCO rep on the board right now?
Caitlin Safford is our MCO. She is here. She's supposed to step out on a phone call.
Okay.
So she is here and able to represent us as the managed care.
And is somebody, who's the proxy if she's not, well, she's not here?
Jorge is the proxy, and I believe with Denise is new to Molina. We were actually just introduced to her the other day, and I think she was.
Okay, just try to keep. Okay. Okay. So welcome everybody. Sorry, I should have done what. Oh, are we done introducing? Did you, Diane?
Yes.
Patrick, did you?
Yeah, we're done.
I forgot to ask people what they were doing for Thanksgiving. So I hope you all have a place at somebody's table.
If not, Ruben's offering.
Yeah, exactly. Multi-day.
There you go. Okay, so we start every meeting with just asking everyone to reflect and remind themselves of the attestation of the conflict of interest and self-dealing transactions. And so if you will take just a minute and look at today's agenda and let us know if you believe you have any conflict of interest on the agenda items. If no appearances now, then when we get to that item, if you believe you do, please notify us at that time. So the first item, which is the consent agenda, is the board meeting minutes that I would ask you to look at. And Ashley, I think I was here at the October meeting, and it doesn't show me as being in attendance. So I would ask you to add me as an attendee.
Oh, we have to, I apologize for that. Sure.
Does anyone else have any additions or corrections to the minutes? If not, we will ask for a motion to approve.
I would move to approve with the amendment.
Second.
Motion by Julie and second by Sandra. Is there any discussion? All in favor?
Aye.
Any opposed?
Aye.
Aye.
Those were all ayes, I think. Yeah. Any abstentions? Okay, so Carol, do you want to lead us through the report and updates?
And so we have a couple of different reports now. We've got the narrative report that everybody can read, but we thought it would be instructive, since we've had some requests for these trackers to be discussed. We have put together a series of kind of trackers to advise the board of where we're at with all of our different project areas, because it's a lot easier to see a tracker and see all the progress that we're making since the beginning of the year when we have these kinds of tools. So I'll let Wes talk about the participating provider workflow, and then everybody kind of has their own tracker that they're going to talk to you about.
So the participating provider workflow looks like this document. It has the blue boxes that go across horizontally in arrows, starting off, moving left to right, right to left, and then left to right at the bottom row. We produced this document before with some updates. As you can see from that red call out, that's essentially where we're at in the process. I'll let Becky talk about participating provider contracts. Some things here that have changed a little bit relating to the objective, which is that box on the right-hand side. Some of the dates there have been updated. First wave participating provider assessments are now expected to be completed by the end of the year. Second wave participating provider assessments will be completed by the beginning of June. As you remember before, there were 23 organizations that were identified for practice transformation, and we sort of split those up into two groups. In this case, we're calling them first and second wave. Under that, begin contracting of first wave participating providers. We expect that to be completed near the end of this month. And then begin contract engagement funding of first wave participating providers by the same time period. There were a few other changes to the boxes in terms of adding the practice transformation implementation work plan, calling out that document by name, and then I believe we added that. We also added the practice transformation work group, which I don't think was in here before. So this is through the end of this year. By next year, we may update this depending upon what particular steps in the progress of this workflow need to be added into it. Any questions about that? Okay.
So for the integrated managed care tracker, you can see we're actually doing really well. We have paid, as of tomorrow, there's a few payments that I put them all in today, but they're going to be paid their full amount of their contract. We have 4 that are
need to turn in their budgets, and a couple that still need to sign their contracts. And then just a little bit of update with the IMC. So the BHO they are going to become the ASO as of January 1st, and Troy Wilson will be the director. And they have put together their board of directors. It's pretty much the same people that were on the board of directors for the BHO. The county commissioners are who they are. And we're still meeting with the providers every other week to address questions that they have with the MCOs or any other issues that they want that they have questions on. And then also we have the early warning systems work group, and we have decided on the indicators that will be tracked starting in January. Right now, the Healthcare Authority is collecting the baseline data for most of the indicators, and they will present them monthly to the providers. So there'll be a monthly meeting starting in February to let people know how the indicators are doing, to see if there's any issues with the integrated managed care switchover.
A couple questions, just
Sure.
for clarification, because we have lots of moving pieces going on. With the IMC, do all of the providers have basically the same statement of work in order to get paid?
Yes. Everybody has the same contract. I don't think anybody has made any changes to them specifically. They all have the same contract. They had to complete the BHAF, the NEHAP, and the billing toolkit in order to get that first wave of 2,000 paid. Then they needed to complete their practice transformation work plan with the navigators and submit a budget, and then a continuity plan that was also produced by the navigators.
Okay.
So right now, you can see like Tri-City Community Health, they still haven't signed their contract, so they haven't gotten paid for it. Once they sign the contract, they can get their 20,000 before they even get their budget in. But so there's still a few people we're still waiting on.
So it's really, for those that haven't completed it, it's a matter of timing, not resistance or.
Right. Yeah, like Catholic Charities are going over their practice work plan tomorrow, and then after they do that and they submit their budget, then they should be able to get paid after that as well.
Remind us what ASO stands for?
Assigned Service
Administrative
Service Organization.
There's a lot of acronyms.
Yes.
So anytime we have a chance to spell it out at least once,
Yes.
do that. Okay. Are there any questions on this?
That on the phone, just for clarity, I'm not sure I understood. So the balance of the allocated funding for the incentive payment will be paid tomorrow? Is that what you said? For the four
No.
agencies?
Yeah, it's for the ones that have already submitted their budget, and all the other have already gone over their work plans and everything. Their payment, there are 5 that will be paid tomorrow. 6 of them had already been paid the previous pay period.
Is comprehensive one of the ones for tomorrow?
No, they have not submitted their budget yet.
What's the delay on the need of contract under Lord's Counseling?
Lourdes has their own issues. That's a whole other subject.
I'm sorry, I'm just asking a question since I'm moving over.
Well, they're in the process of, being bought out, and so their contracts they're having a little bit of difficulties with their legal.
We're not looking at you, Barbara.
Barbara, you're not. There's no finger pointing in here.
Barbara at all. And Lord does have their contract now, which
that's good.
happened this week. So and Barb's working with them.
She just needs to get registered in the portal too.
They're registered in the portal.
Yay! See, they're moving along. This is good.
Yes.
Oh, and then I also wanted to bring up one more thing. One of the things that needs to be addressed by the board is there's a contingency fund of $470,000 that we need to decide on how we're going to distribute that funds. Then the funds were originally allocated by recommendation from a group of behavioral health providers that had got together and decided a formula of how they would be paid.
I'm sorry, is this specific to IMC?
Yes,
Okay.
yeah, and so there's this contingency fund that we need to decide on how can a provider get the funds in the contingency fund. I know we've had a few providers reach out to us asking over and beyond the amount that they've gotten for their incentive dollars for issues, for a technical issue, and also like in order to contract with an MCO. So there are some issues like that I think would be warranted to be able to grant them that through the contingency fund. But that's just something also that we as a board need to decide. Are we going to let the providers decide, or is it something we need to decide? So that's something that does need to be addressed at some point.
Is there a deadline on when those funds need to be used?
No.
No, but a lot of the providers are asking already. I mean, they've received their full contract amount, and now they're asking how they can get into this contingency.
How many of those have spent those, because they're the funds that they've been allocated?
A lot of the budgets, to be honest with you, they're using the funding. Some of them have purchased new EHR systems. They have been, a lot of them are using them for their first, they don't know what they're going to be paid the first 3 months. And that was one of the things that they could use the funding for, was their first 3 months of payment in order to operational expenses for the first 3 months. But the ones that have asked, they've already spent their money. I'll just be honest, Bart's Clinic was one that had come to, they need to install that door in order to contract with Molina. And so they had asked if they can get the money to do that through the contingency fund.
Is this something that would be appropriate for the Budget and Funds Flow Committee to come up with a recommendation on how to access that?
Probably, yeah, that might be a good role. So we're in kind of a transitional period, I would say, in that the BHO is transitioning to the ASO. The BHO had a provider group that met regularly, and so we had given the responsibility on how to allocate the funding of the IMC dollars to the providers. And they use the traditional funding formula from the BHO, but they also set aside some contingency funding for those organizations that really needed to access more funding than what they were being allocated. So I think that that's the situation that we're in. So, you know, it'd be like coming to the board and asking you guys how you should divvy up the money. I think there's a conflict of interest if we're asking the very providers who will be getting the money to how we should divvy it up. So I think that we're coming to the board asking how you guys would like to handle, you know, at least the contingency fund, because it's going to be based on an as-needed basis.
Well, I think there's two things. I think one is going to be requests of providers coming in to use contingency and having a plan to do that. And then there's going to need to be a way to divide the remaining funds that aren't used in that manner. And whether or not those get divided by formula or another way, I think there's going to be two things that are going to be issues.
Right, you're going to use the contingency fund, but then whatever's left, you got to spread. So
Yeah, that makes sense.
But I think with the contingency fund, you want to be careful not to sort of generate a run on the bank.
right, that's what I'm worried about. I'm wondering if people are smelling cash.
And how do
Well,
you
I think they
determine-
definitely have to have valid reason.
I want some.
That's why I'm suggesting that maybe we have the committee that's already, I mean, you chair, do you chair that?
Yeah, I chair that, but it's going to be a whole new arena for that.
Do you think this is appropriate for that group to take on?
I think it would be valuable if that group was going to do it, if we came with some specific guidelines
Okay.
about what the use is potentially.
We
could be.
have guidelines on what the funds can be used for.
Okay.
That was given to us from the Healthcare Authority.
Right, but we don't have a process to apply for them, right?
Not yet, no.
So it seems a couple things, I guess. That's a lot to ask one committee to do that's disassociated from the work. So I think it would be appropriate for the committee to take recommendations from the provider. So have the recommendation for the use of contingency funds come up through the provider group to the fund budget and fund flow group. But the original award was based on priorities. And I think if those are still valid, then that's sort of how you would ask the providers.
Is that true? I'm not sure that that's true.
It was a formula that was developed by the BHO, and you know more about this than I do, Barb, but my understanding was that the BHO had come up with the funding for distribution, and that was the distribution formula that we used for that first round of funding.
My understanding is slightly different. The BHO for years has developed a funding formula per county. Okay. And then we looked at that formula. We, like 15 providers, 17 providers, looked at that formula and tweaked it some. And it was Ed Thornburg from Comprehensive who presented a model where typically the SUD providers, the substance abuse providers, get less money per patient than the mental health providers, and that's how the money flows from the state. Well, we tweaked that so that I believe that the distribution was equal, whether you had a substance abuse provider or a mental health patient. So it wasn't the pure formula from the BHO. It was modified.
And it also built on, it built on the concept that Scott and Dave had introduced, Scott Munson with Fund Down M and Dave Wilson with Merit, that there should be a minimum amount. And so it established a minimum amount of funding and then applied formula to the balance with a withhold for a contingency.
And remind us, Diane, we established a contingency for what purpose?
Well, it was either to provide some kind of trainings or some kind of education for the providers or any other extenuating needs that they would need. Any beyond what they,
circumstances that would find them in a position.
Right.
So is there any commonality between the requests at all with regards to, we would use that, there's a training that they're all asking for, or there's,
unfortunately,
or is it all, everyone out for their own?
Unfortunately, everybody's done out for their own. We've offered different things. We've suggested some different things, and like negotiating and or XBIO as a consultant. I mean, but some of the providers have already hired them on their own, and they didn't want to do a group consensus type thing.
What are some of the things that they're asking for? If you can just kind of off the top of your head, I know you probably don't have the list in front of you.
Well, Bart is the one of the main ones. He's asking for $7,000 to install a disabled door so that they can, because they need to have that done in order to comply to their.
So wouldn't that be something of need?
Oh, yes.
Okay.
That's what I think we need to establish is what are the criteria for somebody to apply for the money, and then after a certain amount of time, and if everybody's already submitted their request, then the rest of the money be split up by that formula that we originally used. That's the way I think of it.
I have a couple questions. So the contingency fund was out of this first chunk of IMC money, right? We're getting another chunk.
Yes, we haven't even discussed the whole.
Right. Yes. So I'm a little, I just want to clarify, because every managed care plan also has their contingency plans for providers to fund them if the billing isn't working correctly. I mean, at least America does. I shouldn't speak on behalf of the others. So Kat and Marissa can speak to theirs. GCACH to speak. Marissa's still really new, so let's not throw her in there.
Got a lot to learn.
But we have contingency plans as well. So I think we need to be really conscientious of what the funding is for, because I'm not clear, like, versus what they got before, and then they're about to get a whole bunch of more money as well. So just making sure the funding is spread in a way that makes sense for capacity building amongst those providers. There's going to be a lot of other things that they're going to have to be doing too to be able to participate in the transformation effort outside of integrated managed care, and they may not need the contingency if every managed care plan has a contingency for them.
So, and to your point, if they can articulate in terms of capacity building why this is a priority and to their own group and bring it forward as a recommendation in the budget. And again, building on the work they're doing with the initial distribution that they receive, have them articulate the value or the need for the contingency fund based in the same terms.
Is it reasonable that there would be, thinking specifically about the contingency, there would be things that would benefit all of them that would be used for those funds? Education.
Yeah, that's a good idea, but the challenge is, and I think that Diane tried to speak to it earlier, is that different organizations are in different places and already have sunk capital costs in different projects. So she mentioned one. Another one I would mention is, I believe Triumph had already purchased an electronic health record, and so having, setting a goal of redistributing for electronic health records wouldn't necessarily benefit them. They already have sunk costs in their health record. Remember the label on these funds was an incentive to go mid adopter, early adopter for the integration, and so I think the providers were asked to each do kind of an internal needs assessment. What are some of the areas where they felt vulnerable and stuff like that? So I think some of that, it's not necessarily proprietary, but I think some of that is internal and does start to breach that recognition of us as independent contractors if we're having to play Mother May I. I don't have a better way of saying that. Someone else may be a little more articulate.
Something you just said triggered something. I'm just throwing out ideas. If it was related to something on the MEHAF that showed a vulnerability or an area that needed improvement, would that be a possible criteria?
I think that makes sense. It's a really nice place to start looking at, because when we did our MEHAF, the reassessment with staff here, what we had in 3 months, we'd already had progress in some areas and no progress in other areas as we did that reassessment. And so I think all of the organizations that are going through that current state analysis in the MEHAF, we're learning about where we're doing well and where we're not doing well. So linking it to that activity might really be helpful. And there may be, if we start there, it may help give us some other ideas on what really moves us towards better integration, better preparation.
That's a good idea. We could do a reassessment and see where the needs are.
Or could we just reduce the amount of contingency and reallocate based on the old allocation? Every one of on this list is going to have some cost somewhere that they need to improve. Like if we don't see
so just split it out.
If we don't see a standard need across the group for something that's a group contingency activity, then why not give them all a boost because they all have areas, and then reduce that contingency fund and make that a more nominal amount, so that way if there is something that were to come up, there would still be a contingency, but in the meantime, we could be putting more hands on all of the money in the hands of all the providers. Everyone has somewhere where they're going to need the money. The money is never enough. Right. It's reality. For building access or for doing anything, it's never enough.
No, and to build on that, a lot of them, when they submit their budgets, they did submit a budget for more than what they were contracted for. So some of them, we already do know what their needs are because they submitted a budget that was over. I don't know.
Actually, like that.
And there have been some environmental changes too that are starting to answer questions. For example, with Greater Columbia BHO being selected as the ASO, that concern that we may have to build new health record interfaces to pass our state-only encounter data upstream has kind of gone off the table. We already have those interfaces built. So that's one example of just a macro environmental factor that's becoming more clear and helping us make more complete decisions.
So do we want to tie the additional dollars to anything or not?
I don't think so. I think the contingency dollars in this budget just pushing back up.
I would actually concur with that. I think it's going to be extremely onerous to look at a process of very small kind of increments. I think initially when we were looking at this, we were looking at whether XPO or some kind of a consultant would come in and really help providers in areas that they have wanted to be assisted in. And that hasn't happened.
No.
And we're so far along in the process now, I think I would concur that it's probably better just to push them out with formulas.
Right.
I mean, to me, the easiest way to do this would be a budget amendment. Okay, you submitted the budget and you've got the amount that's already been allocated to you. We have this another amount based on the same allocation for you to get that, and then an updated budget on how you'll spend those dollars.
And I think if their budget's already exceeded, we should accept those.
Yeah.
Because that would already have defined where those dollars
I'm just
would
thinking
go.
from a contract management, decision-making perspective, like, it seems the simplest to shrink.
So would we need to do an amendment to their contracts to add that money? Yes.
Yeah.
So, okay, so let me just ask that, there seems to be a fair amount of agreement around the table. Is there anybody that doesn't, either on the phone or here in the room that doesn't, that wants to offer additional comments or different comments?
I want
Really different comments.
clarification with that.
Okay, Julie?
So I wasn't here when these budgets were set, so I want to understand, we set aside 475 as contingency, the rest was distributed. What you're proposing, because we thought there was going to be some global need, or what you're proposing is we set a new contingency significantly less, and just kind of hand out.
I think we should just push the full amount.
I don't think we should
No
set a new
contingency.
contingency.
So just
No, I
throw
don't
it
think we should
on the
push it.
same ratio
Because we're
that they
getting
got
that.
it initially.
Right.
So could I ask the providers that might be here, Barb, since you're not, necessarily representing an organization that, well, you're representing Lord, right?
Yes.
So, I mean, kind of everybody has somewhat of a conflict of interest that's talking about this, but from the provider's point of view, you think that would be okay with the providers, just without going back to them to say this is what we want to do, or should we, talk to the providers about this idea, or?
Well, I don't know. The challenge is timing, right? If the providers are saying they need the money now because the implementation should occur on January 1, 6 weeks from now, about 6 weeks from now, if you try to go back to the providers as a group and ask that question, it's going to be challenging around timing. First of all, you're going to have 17 different opinions in the room.
Right.
That's what we found, at least that's what we found the first time.
Okay.
So I think that's challenging. I think the upside of asking the providers is at least they feel involved.
Right.
Like they believe, I believe, that this is their money. This is the provider's money, and they should have some input into that. They are, everybody in that group is a pretty independent thinking person. So those are for me, the upsides and downsides. I don't know the answer. I'll bet Ed has an opinion.
We have a provider meeting right
you
after
have
this.
I'm sorry. Number one, I would have to abstain from any vote, obviously, because of the conflict. But I think if you go back to the communication from Danica as the representative of that group, I believe there was comment on distributing stuff that was not used as a contingency. So there may have been that. I think that was contemplated at the time the recommendation went forward.
Is there a record of that recommendation that would have that we have in our notes somewhere?
We don't have that.
I would guess it would be in the email between Danica and Carol.
And that we would go way back, where I could try to find a
could try to.
Yeah, I was gonna say.
Well,
Several months.
and I guess what I would ask is that this board went back, spent 2 or 3 meetings looking at the formula and taking the input from that group. And then identified the formula that I believe that we took their recommendations into consideration in coming up with the formula that we did achieve. And so if timeliness is somewhat of an issue, by staying with that same formula, we're still staying with their feedback.
I agree.
So can I reframe that then? If we had it to do over again, we did not identify a global need for this 475. So if we knew then what we know now, we would have distributed it all.
Yes.
Let's just correct that.
I think that's correct.
Yes.
The money was,
Now I know.
the money was saved because we thought there was going to be something that would benefit everybody if
Right.
we could
More
provide
unknown.
for it. And that has not, and does not seem to be needed. So therefore, that money is no longer saved, I guess, is what I would say.
Correct.
So is
So under
anybody
the-
comfortable making a motion?
So under the understanding of that, the monies will still have to be spent the way that the original contract had been put out there. There's no new, has to be spent on compliances, education.
No. There would be the same contracts they have.
Yeah.
Okay.
It would just be revised contracts with an updated amount.
Okay. I would move then that the $470,000 that's currently in contingency or reserve be distributed to the 17 participants on the same prorated basis as the initial distribution.
I second that.
A motion from Julie and a second from Ronnie.
So the original money was distributed with two things. There was a baseline, and then there was,
We'll do the same thing. We'll do a similar, we'll work it out. It will be the same.
okay.
So you're going to just proportion it out?
Yes.
Because we have a different amount.
Yeah.
Any further discussion?
And will the board have to approve that?
I think once you approve this, I think that would be all that needs. Yeah.
The formula, I think we've approved the methodology.
Yeah. Perfect. Thank you so much.
Is there any discussion, any further discussion from anyone on the phone? Okay, is everybody clear on the motion?
I'd like to ask for, could you state it one more time, just to make sure?
My motion was that the $470,000 that was initially held in contingency or reserve be distributed to the 17 members using the same formula that the initial distribution was made upon.
Go ahead and say it.
We're gonna get administratively, but that 470 is not the correct number,
Just
right?
continue to put the amount that's in, the amount that's in the contingency fund.
Yeah.
Yeah, the contingency. I don't know the exact amount. I just threw out that number.
It's actually 200.
Close to that.
A lot of verified numbers goes in it, so don't worry.
Okay, so,
You could just put it in my account.
Julie has restated the motion, so all in favor?
Aye.
Aye.
Aye. Is anyone opposed? And if you are abstaining, please say your name.
Darlene.
Sandra, Darlene,
Ed,
Ed, and Caitlin.
We'll just say that the 3 here do support it, we don't have the other one. 2.
Okay, the motion passes. Good discussion.
Sorry, whistle. Bring it on.
May I ask a question? I wanted to go back to where we're at with the IMC and the billing testing, because that seems to be the next big thing that has to happen. So could you guys let us know where we're at with billing testing?
It's different plan. I know that we have some providers about to start testing here.
Okay.
They haven't started yet, I don't believe. We have to get a lot of contract shells, what we call shells, in place in our system for that to start happening at AmeriGroup. So that's almost complete, and testing will be happening a lot over the next couple of weeks.
Okay.
From DHW's perspective, we have been ready to test for about 3 weeks. I think timing-wise, so we're ready to test. I think we've been in the process of testing. Some providers don't need it. They are ready and they have expressed that they are fine. And others are moving forward with that engagement. Also, from our business and operations team, they expect next week to be the sort of start of busy season. Happy Thanksgiving, and start of really busy testing season. So.
Thank you.
And I guess just an acknowledgement, when you look at this tracker, you can see that there has been a lot of time that the navigators have spent with the BHO. And I just wanted to point that out because if you look at Somerset, there's many, many different meetings that have to occur with the provider organizations in order to get this work done. And I just wanted to thank the navigators and Sam for putting in this time. I think it's made a huge difference in the readiness of our behavioral health providers. And I don't know what the MCOs think, but I think it's really helped us develop a trusting relationship with some of the BHO providers too that we weren't necessarily familiar with. It's been a really good experience, I think, for Greater Columbia.
I think we've really valued the role the ACH has taken on in coordinating the BH providers. In some of the other regions, the ASOs are the ones that are doing that. And I think the work becomes disjointed in that case because IMC is a component of transformation. And so it's a little bit weird. We'll have to get used to that, I think, for 2019 in our 2020 regions, or the ones that are going in July. But we do appreciate all the work you guys have done, and Diane has been really fantastic. So thank you.
Thanks.
Diane, along with that, you mentioned the early warning system.
Yes.
And I know this sort of fits into part of that, but are you going to talk a little bit more about that? Is that somewhere in here or?
I can talk about it right now.
Okay.
So the early warning system work group, the Healthcare Authority actually came up with some really good standard indicators. And I should have, I think I have a copy of it if I needed to pass it around. But anyways, the standard indicators, here we go. There's provider payments, there's the EDI data, and then the crisis system and the state hospital. And then we added a category for provider input. And so each of these indicators will
You guys don't have this.
be collected, and I can send this out so you guys can see, by Healthcare Authority. They're actually going to collect the data and then present it monthly to the providers so that they know where they're at. And if there's any, increase or decrease, or if they see that the, payments, there's like a provider not getting paid, then that's one of the measures that they're looking at. So they'll be hosting these webinars, and they'll start in February. They'll get the data from July, and then they'll start, from January, and then they'll start in February. But the whole month of January, they're going to start these rapid response calls, which basically they're going to happen 3 days a week. And it's basically going over this data to make sure that things are going good. Anything that's not going the way that they feel needs to be addressed, and those will be addressed on those calls. So I can also send that out to if anybody, all the providers have it, but if anybody else wants to participate in those calls, they can participate in those calls.
Well, I think it would be helpful for the board to know, the non-payment ones, what kinds of indicators are these?
They are going to do the denied encounter claims. They're also going to do, let's see what else. The number of claims that are rejected, the number of claims that are received and paid, and then also the Healthcare Authority is having a meeting with the MCOs about what other provider metrics that they, like the timeliness between the payments, making sure that they're paid in a timely manner, the claims are being paid in a timely manner.
This is where testing
Exactly.
is very important, because as we're trying to track that information, if we can ensure that as providers are testing leading up to 1/1,
then they have an understanding of what those gaps in their system may be. And in that, all the provider symposiums, we've also provided the most common rejected and denied claims as well within integrated managed care.
I think my jet lag is catching up with me. I know in the EWS work groups that I've attended, we've been talking about other indicators besides the payment indicators that we want to pay attention to. Have those been pretty much settled
so there's two that they have decided on is the number of screenings that they have. So the providers will provide those to me, and then I'll keep those and provide. And the other one is the type of assessment, so the different CPT codes. We did talk about the number of referrals that the providers would have to crisis, but the last early warning system meeting, they thought that may be too burdensome for the providers to collect because it's not something that they have in their ready accessible for it. But I am going to ask them to get all the providers at the meeting after this one about it. So just to see if that really is something, because I think it would be a good thing to get, because then we can see compared to what the providers are sending people to what the actual crisis providers are seeing. So
what we're learning about.
This is Ed, and sorry, Les.
Yeah. Go ahead, Ed.
Well, I'm sorry, I started talking over you. So the one that I still, and I know some people are tired of me saying this, but please listen. Can we get the JBRS reporting of Medicaid suspensions of people going into jail and monitor that number to make sure that we're not seeing people moving out of the behavioral health system into the jail system and corrections? In other words, are we seeing the suspensions and the reconnections in the same ratios we were prior to integration?
Unfortunately, Ed, there's no way to track that data.
Yes, there is. Use the jail-based reporting system that's turning it off and on.
The problem with that is there's a lag. So the Healthcare Authority has researched this. What happens is that if, say, a person goes into jail on January 15th, their Medicaid is still good until January 30th. So it's not going to go
no longer true.
January 1st.
That is no longer true. It suspends when they report them, it is booked in, and it restarts when they discharge.
But in their systems, it's not showing that. There's a lag time in their system, and that's why the Healthcare Authority said that they cannot collect that data.
Use the direct inputs from JBRS.
Well, we can talk about, Healthcare Authority will be on this call. If you're going to be on the call at the end of today, then you can talk about that. But
And I would agree with Diane, just to bring it up with the Healthcare Authority, we have also, from a managed care perspective, had challenges in having access to JBRS, and so the idea that information is actually available for tracking is a challenge. Yeah. So I think that idea is right. I think it's, again, this ongoing challenge of connectivity across agency and county-based systems as we think about that overarching challenge. But I bring it up with the healthcare. I think we can bring it up. It could be, an ongoing thing we are all trying to work on.
So it sounds like it's important that you be part of that conversation, Ed, if that's important.
And to answer Les's question, the reason we're doing this is because the Healthcare Authority wants to ensure that fully integrated managed care is not being hindered through this transition of providers having to bill or relate directly with the MCOs. To this point, the providers under the BHO system have been working with the BHO. This is a whole new ballgame. So these are early warning indicators that would let us know whether or not there's a glitch in the way that the contracts are being implemented at the provider level. Is that right, you guys? Okay.
So, and that's why I was hoping that and maybe at the next board meeting, we could look at some of those metrics in terms
definitely.
of, what kinds of things, and the group said, I missed this month's meeting, but the last ones we were talking about, how do we know if we're creating an access problem? How do we know, definitely the billing needs to be a big thing, but what other problems should be considered an early, a sign of a problem?
And see, when I think of something, I'm thinking of referrals and
Yep.
And completed referrals as being a barrier, but that's a barrier today. So I don't know how
So
that
the
would
question is, does that get
interpret.
better or worse?
Okay.
As a result of the IMC?
Yeah, because that's what I see from my end.
Yep, you're on the right track.
I think that's everything from my end.
Are you telling us that's enough?
I think I got everything down.
Okay, tell him.
My turn.
Is that you, Ruben?
I always follow a lively conversation. Well, this tracker is to track the local health improvement network's progress on allocating the community health funds. And I apologize for not writing a heading up there. I did have it on the task, down, but it doesn't show up. So what this is pretty much the progress of the local health improvement networks on the managing of the community health fund. So as you can see there, right now, the 3 lanes that are pretty much current to where I would like for them to be is Southeast Washington Rural Health Network, Whitman County Health Network, and Yakima County Health Care Coalition. They have captured the consumer voice on what social determinants of health are most pressing in their communities. They have selected their social determinant priorities out of that those surveys, that consumer voice. They've also selected their third-party administrator, and the only thing that remains is for them to work with me to put together some metrics language on the contract. We have sent out the contract already to all the third-party administrators. They're looking at it. We've had several conversations with Yakima Valley Community Foundation. So the 3 that are not quite there with the rest, with the other 3 is Benton Franklin Community Health Alliance. I checked them off because on the 28th of this month, they're going to meet to select those social determinants and to actually to finish their capturing the consumer voice. Today is the last day of their survey. It looks like they're going to capture about 200 surveys or so. So today is the last day, and Tri-Cities Community Health is helping them a lot conducting those surveys. So on the 28th is when they're going to narrow down those social determinants of health they want to address. So they're going to catch up pretty much at the end of this month. Kittitas, they ran into a roadblock. They selected the survey. They were going to start having some of the providers conduct those surveys, but I guess they got some trouble getting providers to conduct the survey.
Would you like an update?
Well, yeah.
We actually concluded them today.
Oh,
so they're
great.
Yeah, so
right.
we got to the FQHC and then our primary care clinic, the hospital. So we got a really nice sampling, and they're starting that work.
Perfect. So so the top one is checked off. So but you haven't selected which, you haven't narrowed down to which.
They're with the data folks just got their hands on the survey.
Perfect. Okay, that's.
Can you tell us who the third-party administrators are, except for Yakima Valley Foundation?
So Yakima Valley Community Foundation, they're going to work with Yakima County Healthcare Coalition. They're going to work with Kittitas Health Network as well. So they're going to do 2. Blue Mountain Community Foundation is going to do Walla Walla's, Lynn, and they're going to do Southeast Washington.
Okay.
Here, the Tri-Cities, Benton Franklin Community Health Coalition is going to be 3 Rivers Community Foundation.
Okay.
And in Whitman County, it's going to be the Hospital Foundation.
Memorial.
Memorial, yeah. And so, Walla Walla, they just started a little late in this process, so they're just a little behind altogether. But those are right now the only challenge just they're facing, and I'm glad to hear that update on Kittitas. Any questions?
Anybody on the phone have any questions?
Thank you.
Hey, Rhonda, just a reminder that last month, the board approved that second year allocation to go out. So we'll be pushing out about $1.3 million to these local health improvement network third-party administrators.
So I guess my question is, you said that Benton Franklin Community Health Alliance had not done their social determinants of health priority,
Yeah,
but there's an X in that spot.
I know, and I mentioned that today's the last day of their surveys, and they're on the 28th.
So it's really not an X yet.
No.
Okay, because I've seen that a couple times when I'm looking at things. I see an X and then someone says, well, it's really not happened, and then I'm wondering where we're.
Yeah, I should have written the date instead of when they're gonna happen, but since they're gonna do it this month, I guess that's what my thinking was at the time.
So it's not completed, this is happening this month?
Yes.
Okay, now I understand better, thank you.
For them, that's what it means,
Makes more
yeah.
sense.
Martine or Jenna, who's doing the thing?
I am. Do you want to make it a little bit bigger?
Oh, you can see it.
I can see it, but just for everybody else. So this is a tracker that we're using for patient-centered medical homes. All 23 organizations are listed on there, and the X's means that we've completed that part of the tracker for that organization. Two of the organizations on there, Tri-Cities Community Health and Lords, are further along since Sam has been working with them for a few months now. Jenna and myself are on the road quite a bit all over the 9 counties. But for the most part, we've almost completed all of the PCMH assessments. If we haven't, you guys are on our calendar. There's only one organization we haven't been able to contact since we started PCMH, and PTIWs are being developed, the practice transformation implementation work plans, after we meet and complete the PCMH assessment. And then we go out again and meet and present it to you guys, and a lot of the organizations are on the calendar for us to go out and visit. And then after that, hopefully after today, the contract gets approved and then get it sent out to you guys. You guys can sign it and get your money. Any questions on the tracker?
So what's it mean if you're highlighted in red?
In red, you're an exemplar organization. So those are the ones that are, for example, Farm Workers Clinic, Yakima Neighborhood Health Services, they're already PCMH certified. So we're using those as exemplar clinics for other organizations.
And the yellow versus the blue?
The yellow was, the goal was to have all of the assessments done by the end of this year, which from what it looks like there, we'll be able to at least complete all of the PCMH assessments by the end of this year.
So when we talked about first wave is yellow, second wave is blue. When we're looking at the workflow diagram.
Mm-hmm. And a lot of the times too, it depends, since, you know, there's different people involved from the organizations, from different departments. It falls a lot too on when everybody has time to meet, because we like everybody to have a seat at the table so they can be on the same page. So sometimes it's kind of hard to coordinate, you know, that time, but we try, Jenna and I try our best to work with the times that you guys are available.
Thank you. Portal tracker?
So just a question, so for the things that are not assessments, Martina and Jenna, so there's a whole list of things. We might just add that some of these things will be negotiated in the contract, so they can't actually be decided until the contract is signed. So for example, the resources for care coordination, the ED and follow-up, within the contract, the providers will have choices of what they want to choose in terms of their measures. So we won't be able to fill those X's out until the contract is out.
And to touch back a little bit on that as well, on some of the items on the tracker, if, for example, there's reports that need to be pulled out but aren't, the EHR is not able to do it, then we might have to take a step back and kind of look at the foundational level of the EHR and see why that's not happening, and see how we can assist to make that happen. So that the extra work is not, you know, it's not extra work added to that organization.
Okay, we have no more questions on to the next tracker, if you will. So this top, spreadsheet, you guys have seen a lot. This talks about our payment to our providers for submitting their LOI and, registering in the portal. Ryan.
Sierra.
We did get one new one this month, Columbia Fire, so I thank them for registering the portal, and they will be paid on Friday. We got Lord, unfortunately, after the payment date, so they will get theirs next pay period. What I want to talk about also, because that came up, with Barb earlier, the portal is going to be under construction. This Friday is our last set of payments in the portal until December 28th. So,
That might get them to move.
so sorry for those of you who didn't make the cut. Right.
Well, it'd be a good Christmas present for somebody, right? Okay, so they can wait for a minute.
So I'm really glad. So we'll have, as soon as we'll get Lord's off of the, paid off the next, hopefully we'll get another one. And then, so we'll have 4 left, and that'll be fantastic. 4 out of the 52, I think it's great. So then the bottom spreadsheet, half of the spreadsheet is the tracker for payments for our BHO contracts, which we were just talking about. And Friday, there are almost $500,000 worth of payments being paid out.
So, going back to our earlier conversation, if the portal's down until December 28th, the reallocation of the IMC funds, that means potentially they won't be able to receive those until December 28th.
Correct.
Okay.
But I think they'll give them time to redo their budgets and, sign amendments. Yeah, I think it'll work out.
Okay.
Like, tell me a month away. It'll be like Christmas present.
I think the other notable thing is that you'll notice in the upper half, there's a bunch of stars beside some of these funds. And these funds were already approved by the board of directors, the base population health fund for PCMH. So we're expecting that once the contracts are signed, because this funding is actually attached to the contract, but as soon as those contracts are signed, that funding can be released because that's base population health funding. So that's not necessarily tied to a deliverable, it's really just tied more to the contract. So we should be seeing some really big payments by the end of the year, hopefully.
I hope so. So that contract is on the agenda today also for you guys to approve, so we can get that out to the providers.
Unfortunately.
Any questions? All right, thank you, guys. All right, financials. Thank you,
You're not done.
Thank you, Brian.
Okay. So, let's go to the, yeah. Okay. So we had our finance committee meeting, this week, and I think everything went well. Our treasurer approved our expenses thus far. So this sheet you guys are looking at here is the budget versus actual for FY 2018, which we're getting close to the end. The top box is our total revenues. Nothing new in there. System funding, 114,000 is what we've actually received for first half, and then we've received 34,190 recently that we reallocated for our vehicles, which we talked about. Investments, Art America money market account, that shows our interest that we've earned for the year. Expenditures, we didn't have anything out of the ordinary this month to report on. Just the usual payroll.
Yeah,
I don't remember.
obviously the finance committee meeting obviously went very well. There were no surprises, straight payroll and monthly operating expenses were within expectations. GCACH in their checking account, to allow them the flexibility to do things that they need to do. We talked a little bit about, you may recall last month, we had, agreed to increase the credit limit on the credit card. That's been accomplished. So that was good to hear. The other thing that we talked about in the meeting, was, we felt like there was probably a need to at least think about, discuss a little bit more, opportunities to invest these, funds. Again, there's a lot of funds, and to be drawing down small amounts of interest, maybe we need to do a little bit more of an aggressive pursuit of some interest against the dollars. So my recommendation, I think, was to talk to the, you're going to talk to the financial counselors
Yes,
with the 401k, for example.
Yes.
Maybe get a start there.
Yes, get some ideas rolling
Yeah.
about how we could, because right now we put most of the money into this money market account and then we just get our, interest off of it. This year, we reallocated it to other areas where we might have gone over budget or other areas where we needed some extra funding. And so what we talked about was not doing that this year and having a different plan for.
So are we looking for mutual funds or?
We don't know.
We don't know
I
yet.
think we just want to get the conversation started to get some ideas to bring forward to the group.
Aren't there rules about drawing interest on federal funds?
I think there's rules on the amount of risk. You don't take any risk against those dollars.
Right. Which
And that's last year we had to give money back because we were drawing interest on it.
But that was STEM funding.
Yeah.
That was STEM fund. And so there's a difference?
Yeah.
Yes.
They're both federal dollars, aren't they?
No, district dollars are not federal dollars.
So you're talking about district dollars?
Yeah.
And again, this is a perfect example of why it's useful to have somebody who knows that stuff take a look at it.
Thank you. Appreciate that.
But no, I mean, I completely agree. You know, I remember being at a public hospital at one point on the East Coast, and there was a provision that you could take no risk on public funds. It's fine, but as a result, you get virtually no return on $250 million. So we just want to maybe explore that opportunity as we go forward. But again, it was a very good, very straightforward meeting. I think these guys have done a nice job and keeping that $50,000 liquid in these accounts. No surprises. No surprises. It's always good.
Was that a motion?
Yeah, I would make a motion that we go ahead and approve or accept these financial statements.
I second it. Ronnie? Yeah.
She's not going to talk about any of the others just because these all reflect, this is all
They're all
reflected in
backed
this,
up. Correct.
this one. Yeah,
Right.
but I looked through them all and I thought, oh, it's going to take a long time.
No, this is it. Yeah, all of the detail is
Yeah.
Reflected.
Right. That was the decision I think you made last month.
Yeah.
That I would just go
Makes
over
a
the
lot of sense.
highlights, and if you want to look at the details, you're more than welcome.
So I did have a question because I want to know what budget means versus actual. Because sometimes budget means budget is up to date, and sometimes budget means the whole year's budget.
This
So-
was budgeted up to date.
Up to date. Okay, that's what I wanted to make sure,
Thank
because if we've already spent 100%, I'm kind of worried about it. So, okay, that's why I just wanted to clarify. Thank you.
Any further discussion? All in favor?
Aye.
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 Anyone opposed? Any abstentions? Okay, thank you very much. Good job. This is Form 990 review.
Okay, so that's our next packet here.
Thank you.
So, I'm on a roll. So this just talks about our, has a summary of our, so this is a form that we filled out, the financial group, myself and Kylie, with Moss Adams to send in, which we're going to send today, hopefully once you guys approve it, to the Department of Treasury, the IRS. It talks about our expenses for the year, funding that we received, funding that was sent out. I don't think there's anything in here that you guys haven't been told already. There's no surprises.
This, just to clarify, this was prepared by Moss Adams.
This is prepared, so Moss Adams sent this document to me electronically, and I went through and filled in all those X's that you see on the first couple pages, answering your questions. Finally, I went to fit it together and filled in all of the dollar amounts, and then Moss Adams reviewed it and printed it for us.
And our bylaws say that the board needs to review it,
Right.
not necessarily approve it, right?
Correct. So this is just for your review, and then for our president to sign.
Okay.
And if you have any questions on it.
Okay.
haven't read these very much, so I don't know how to read if there's a flag.
Okay.
I mean, so you understand what I'm saying? Because there's an awful lot of X's to look at and stuff. So
that's
is
why we
yes
had it.
good or is yes bad? I mean,
That's why we had a CPA do it.
Right.
Yeah.
Okay, so that's,
There's
Yes.
a cover letter here from our CPA that talks about how they, how this was prepared
okay.
for, Greater Columbia.
I would say if you'd like to go through this in detail, schedule time with Becky.
Ask Julie. I've looked at a lot of 990s, and they're a very low-risk document. It just takes your financial information and distributes it between programs and administration, the way the IRS requires it be done.
If you'd like, you can get a GuideStar.com or .org membership, and you can look at 990s all day and get nothing.
You can do that without a membership.
Once like the free login or whatever, they give you free login. Just practice.
It's a very cumbersome document, I agree. But
Yeah.
Unless your name is on it, so it's going to the IRS.
Yeah, I know.
They're gonna be watching you.
That's true, that's a good point. It does list all
Shows
your.
how much money I'm making off it.
Yeah.
Yes.
So on the agenda, this says approval, but we really don't require the approval. Right?
Right.
Did you want an approval, Carol?
Sure, yeah.
Okay,
I'd move to approve the 990
Okay.
presented by.
okay. And second by, who was that?
That was me.
Okay.
Oh,
Sorry. All in favor of the 990 being submitted
Aye.
today?
Aye.
Aye.
Anyone opposed? Dan, is that you?
I said aye.
Okay. I was hoping you could say that with a little more enthusiasm, please. It's just not sounding like Dan. I'm not really capturing his voice today. So, okay, I'm sorry. My apologies. Is there anyone opposed? And are there any abstentions? Okay, great. Thank you very much. Becky, scholarship policy.
Oh, this is Carol.
Okay, Carol.
I was wondering about that. So we have had several requests about whether or not Greater Columbia ACH has either a scholarship and or a sponsorship policy. We've actually been directly requested of several organizations to sponsor events. So before we got too far into our 2019 budget cycle, I thought it would be good to have a discussion around having policies around scholarships and sponsorships. When we're talking about workforce, I think that one way to grow our own is to make some funding available for people that might need a scholarship in order to pursue a degree in a field in behavioral health or, medical profession. And I know from my own personal experience, we have a Rotary Club that distributes scholarships to individuals. So if we wanted to go that route, or if we wanted to be more directly related to that, we could do that. So this is just a kind of an opening dialogue to talk about whether or not Greater Columbia ACH Board of Directors would like to have any kind of policies for sponsorships or scholarships. And so I asked Kylie. Actually, Kylie wrote both of these policies, and she used different models. So for the scholarship policy, there's actually WSU Tri-Cities, WSU Educational System actually has their own forms and their own methods of distributing the scholarships. So it's really up to us whether or not we want to set aside any funding for these opportunities.
So one idea, if we do set aside funds, is to use the interest in that capacity.
Oh, that's a good idea.
Yeah.
So, Carol, excuse me, Carol and Rhonda, this is Lori. And, workforce development, I think, is very important, especially in a medically underserved. But I would like to expand, if you're going to do that, expand it, because we're also looking at social determinants of health, and social work or related field is very applicable to the mission of the Greater Columbia ACH, as well as traditional medical. So that would be my input on the policy.
This is Ed with Comprehensive. I only had two thoughts that I would want to make sure we were okay on. One would be avoiding the impression, we've been told, I think, that this funding is Medicaid funding. So avoiding the impression that we're gifting public funds. How do we test that we do this without getting in trouble? The second piece is, as the scholarship policy is written now, there's not a lot of certainty that the money being used in the scholarship actually results in somebody entering the field. And so one way to maybe get both birds with one stone is to look at the organizations that currently already have an internal tuition assistance program and do it as a match to their policy-driven internal benefits, which are a retention benefit, to try to help people grow within their field, within the discipline.
I would really support that. This is Julie. I would support that because I've worked with a couple of scholarship programs and they have high failure rates. And you end up funding 2 quarters but supporting or matching a program, I think would.
I think the other thing that is an option is to look at supporting at the end instead of the beginning of a career.
That's a good idea.
So if you're supporting that last year that somebody is in a program, your likelihood of having a graduation rate and having somebody enter into the workforce is much higher than supporting the beginning.
When you say program, are you thinking vocational program, AA program, bachelor's program? Does it matter?
I think there's some tax implications with the master's program.
For what? Speak up a little, Julie.
I think there's some tax implications with the master's program, but any vocational programs, I think all of those serve the need.
I do think that we need to look at the definition of medical field.
Yeah.
Take into account what Lori said as well.
A different word might be better. Healthcare.
Social service.
So this is,
Would it be something with advertising, like on like a CBC scholarship page or something like that? Or
when we think about the number of universities and community colleges within our own 9-county system, we're probably not even going to have enough money to make a dent, really. But we've got WSU, we've got Heritage, we've got Central Washington, we've got Yakima Community College, CBC, Walla Walla. There's quite a number of educational institutions. I think that trick will be, how do we get the word out and how do we fund these?
Well, use your example. How do Rotary clubs?
We have a special committee that's set up that goes through every single application. We have 52 applications a year. So that's why I'm thinking if we could use an already devised system so that we're not trying to score and grade all of these different kids that need financial assistance, and it's usually based on financial assistance is the reason that they're applying anyway. So I think it would meet the test of Medicaid. I hope. Then that would be my preferred, track. Otherwise, we could spend a lot of time grading and scoring scholarships.
I think that while I was with Pride Foundation, or still am, but every year I volunteered to review scholarships.
And it is like, I get 30 on my plate, if there's only a few of us that are volunteering. So we reach out to the community to help with the volunteer part of that, to fill that. I like the aspect that they accept any kind of educational, forward. So that's trade schools included. And I appreciate that they are focused on a specific group of people, which is their ally and LGBT identifying. So I think that when we go forward with this, because we are looking at Medicaid recipients and that's what we do, I think that trying to push that out to that community to go forward, because there's a lot of people that are CHWs and peers that want to, I'm one of those, that want to get that education piece, can't find the funding for it, or have to go into real debt in order to get that, and financially can't afford that. So I think this is a wonderful idea. I think that when we're looking at the scope of that, to look at those areas, the CHWs and the peer support going forward, that gets. And there's training all the time. There's conferences that you can advertise to, and you also have groups of people that would be willing to volunteer to look over those and score for that. And I think the partnership with matching to already existing funding.
So the idea of training scholarships toward a degree and scholarships toward a conference. Would you want to allow for both?
Is that covered by the sponsor?
That's what I'm asking.
I really like the sponsorship.
The sponsorship, I was thinking that was more like for organizations and for events.
Like in the yearbook.
Yeah.
Oh, I was thinking more of like conference and CME or CPE.
How would you do, yeah. I mean, it could go either way. I guess that's why I'm throwing it on the table.
I was thinking the same way you were, Steph.
So you're thinking that the scholarship could also be for conferences and continuing education?
Mm-hmm.
Wow.
So what about externship?
Pardon?
Externship. So I'm finishing my master's in social work. I need to get so many hours in. This organization is a meeting a high needs group, and they just don't have a lot of stuff. But we'll pay for that person to work with you for the summer.
That would be cool.
So
It's
you
learning.
understand what I'm saying?
You know, unless we have a lot of funds to do for this.
Yeah, probably.
I really think we need to think about how to really funnel it. Now, that would be one way to look at just doing internships and externships and not necessarily doing actual tuition. But that's one, because you're getting people that are close to the field then.
Yeah, and you're getting them somewhere that hopefully that they may
Absolutely.
stay with, or because you're looking for a place to get a job, and I don't know.
It's not a heck of a lot of money. I mean, there's a lot of different things you can do there.
Yeah.
That's a great idea.
So when I saw this one, we're trying to get the Kittitas County Medical Society get a program together to support Suboxone waiver training. And that, I thought, wow, this would be a good way to bring that curriculum to 25 medical providers at the same time. So I don't know if that wasn't the
So
intent.
are you talking about scholarship or the
Sponsors.
Are you talking like MAT training for them? I think that's something that's
coming out of workforce.
Yeah, that we already are accounting for. We're wanting to provide that for the providers.
So developing them to do that is not workforce. So moving them to do that is not, you're looking for initial workforce?
Yeah, the ones that are already working, current.
Let me ask, you said you've been getting lots of requests. What kinds of where are the requests coming from?
Okay, so for the sponsorships, I think that we had one from the Youth Suicide and Prevention Fund or event.
To sponsor an event.
Yes.
Okay.
We've had requests from Yakima. We had one from the
Jefferson schools.
right.
the chaplaincy also asked us for a sponsorship for a keynote speaker for one of their events around end-of-life care. So we have been getting some requests.
But that's not workforce.
It's not
Well,
workforce,
I'm not
it's more
sure
sponsorship.
How does that advance what we're trying to do?
End-of-life care could potentially address high-cost, high-need individuals.
Okay.
Suicide prevention.
No, I understand that one, but again, I don't mean to
That's okay.
Yeah.
So what if we,
I think it
mean,
is.
is there, maybe would want to have an ad hoc group to kind of fish some of this out? We're not really have a deadline for this, right?
No, but it was just, if we're gonna put anything in the budget, and it would be nice to have some funding set aside now so that we can, speak to that. And now that I'm on the Workforce Council with Dan, there has been some recommendations coming out of the Behavioral Health Task Force in terms of having these kinds of opportunities available, especially in behavioral health, because there's such a large need of getting people into behavioral health professions. So one of their recommendations at the state level was to have some kind of a scholarship fund too. So I think that's very consistent with what we're trying to do as a state, but we might be a little bit ahead of the curve. So I would like to, work with Dan on maybe fully fleshing out more of this policy to see if we can narrow the focus, because otherwise we're going to be all over the place. And I think that there is a true need in the behavioral health field to have more opportunities for scholarships.
So could I just suggest that we think about scholarships as people, and we think about sponsorships as more community.
Community.
Right. Just for our own mindset.
And I think that when we're doing the community things, it's important because of the work that we're doing.
Yeah.
It's making those connections. It's networking and becoming viable partners with our community.
Great.
And I think it's important.
I can live with that. I guess for the reason I'm short on those thoughts,
You don't have to explain.
well, events feel like one and done,
Yeah.
They are. Scholarships and some of the other stuff feels a lot more like your thought with the Suboxone education. I think it's great. And that, to
I
me,
agree.
That's almost more like investments, and I like that a lot.
Yeah.
But those can also be scholarships. Let's say it's about trading people.
Yeah. So I guess that's where I'm from.
So Dan, are you willing to share this an ad hoc task force?
Yeah, I've been trying to chime in here a little bit. I concur with most of what's been said, going back to what Lori said regarding kind of services being included. And also that this is a fairly robust conversation across the state, particularly about like loan rate repayment. The Washington State Achievement Council has been looking particularly at adding community college education to their recipients of grants, but really focused more on nursing. But I think it's a really good idea to differentiate between sponsorship, which is a good idea, and grow your own workforce policy that's specific to our 9-county area, which is another big topic locally, regionally, and across the state. Anything that we do has to be a kind of a grow your own focus.
Okay. Rhonda? Is there anybody else that would like to?
I just wanted, we have a couple comments in the sector.
Okay.
Emailing. So I think the first is it would be helpful from a workforce development standpoint to understand like what are the goals of workforce development for Greater Columbia, and then how does the scholarship policy connect to those goals? So it might help narrow the focus. And I think we talked a lot about workforce in the state, like Dan is saying, like there's a million ideas right now, and not every region has the same issues, so it would be helpful just to have a little bit more refinement. I think you're getting there anyway with the focusing point, but goals of the overall strategy would be great, because what if something else comes up in like a year, then at least we know, okay, well, we can develop a program because it's our goal in the next 4 years to reach this point, either for BH providers or medical or whatever, in between community orgs, but at least something around that. So it would be great if the committee could work on that as well. That's now becoming more of a committee than a task force. But,
well, and maybe this is a task that we ask the workforce committee that we have to look at,
Of which Dan is the
of which Dan is the chair. That's
Yeah.
the next one.
So maybe just bring it to the workforce.
I think that's a great idea.
And then
Is your committee coming up with other thoughts?
I know. I catch the rep. No, she's not. The other couple of thoughts were that equity be a part of this. How are we including equity in the envisioning of workforce development and any sort of scholarship policy that we put out there? And Marissa actually offered a number of edits just to this policy because she has a background in higher education that sort of shore up the legality of the policy, but also some ideas around the equity part of it. So I'll forward those to you, Carol, so you can see them. And then.
And you want to be on the committee too, right?
I agree.
I'll see how I can fit it in.
Great
Is
suggestion.
that Caitlin?
It was.
Yeah, well, come on, Caitlin.
No, I'm not being on the committee. Sorry, Dan.
So Dan, rather than asking you to take on a new ad hoc group, we're asking you to have this be a project of your workforce committee, if you didn't pick up on that.
Yeah, I did, thanks.
See, there goes that enthusiasm.
Oh, he's so happy today.
I know, okay. All right, well, thank you very much. So let me just ask, so sponsorship is a little bit different. So do we want the workforce committee to take that on, or do we want to have a separate group look at maybe possible guidelines for a sponsorship committee?
I don't think sponsorship is necessarily workforce. It's more
I agree.
public
No,
relations.
it's
That's
more
what I'm
public.
So do we have a communications committee?
Communications, I think that's the people that would take it.
So could we ask the communications committee maybe to look at that? Who is our communications committee?
Lauren.
Lauren?
Me.
Okay, who chairs that one?
Madeline.
Yeah. So good, Madeline's not here.
She was on the phone.
Oh, she's on the phone. Oh, here. Madeline, are you still there?
Madeline, she's looking
Yes,
at your name.
yes.
Okay,
Yes,
so
I'm
would you?
still here.
Would your group be willing to take a look at the sponsorship criteria and make some recommendations for that?
Certainly. And who else is on it?
Sandra said she is.
Okay.
And we'll ask the staff to remind us
Yeah.
who the rest of that is.
Lauren will take care.
There used to be an MCO representative on it. I think a Brisa Guajardo was on it.
Oh, yeah, she's really
Right.
good
Yeah.
on the
Is it
communication.
on our
part.
website?
Okay, well, Lauren will be in touch with you.
Okay.
Okay, sounds good.
Okay, thank you, Lauren. You'll coordinate that with Madeline. And then, okay, so let's move it along. We've got the final contract for the practice transformation and PCMA.
Okay, so, you guys have seen that last month, I believe, I showed you the template kind of that I wanted to use for contracts moving forward. I liked that language, so we took that language, I took that language to start off as a base, and then, I worked with Sam and Carol and, the rest of the group to kind of, add in verbiage about the patient-centered medical homes and what this contract is really about. So, I don't want to go into the depth into the language of the contract unless anybody has any questions. I kind of want to talk about the exhibits that are attached because I think that they are more interesting.
Well, this we pretty much approved last
Right,
time.
yeah.
Yes.
Yeah, we just added in, like I said, language about what this contract is about and the recital specific to patient-centered medical homes. We added in the completion date, and then we added all of these exhibits, which I think are the exciting part. So the first exhibit, at the last budget and fund flow meeting, I think it was, we talked about the methodology about surrounding how these things are distributed. And so this is actually, this is a sample of what a provider would receive out of this contract. So the total dollar amount was $204,375. And then the spreadsheet talks about the milestones, which is the bidirectional integration, empanelment, risk stratification, all the things that you guys have seen. But what you haven't seen is how the dollar values fit into the table. And Sam did an amazing job of allocating about allocating points, a point system to all of this that I still don't really understand. 'Cause, and so and then there's further documents that will come about with the contract that, Sam has developed also that go into really great detail about what each of these deliverables and milestones, what has to be done to earn the full point value, to earn the full dollar amount for each of these. And then she also delegated them all out into quarters. So this would be starting, first quarter, January 2019 through the fourth quarter, January 2019.
So, and we also had some great assistance from Dan Bazzini,
Oh
who
my
actually
gosh.
did all the math.
Dan Bazzini is incredible with the spreadsheet. I tried to do it and was about to pull out my hair and Carol goes, oh, Dan.
And I think
So,
he's on the line.
And Dan, if you're on the line, thank you so much. He pulled this out in like 30 minutes. He's just a whiz with the spreadsheet. And yeah, definitely big credit to Dan. So, do we have any questions about this or want to talk to me about it later? We can.
Yeah.
It is a little complicated.
It is very complicated.
Sort of the underlying piece of that is tied to this document here.
This is the formula that came from the Budget and
Yeah.
Finance
Yeah.
Committee, just to
Yes,
clarify.
so we showed like I said, the methodology of how this is gonna happen at the Budget and Finance Committee, and then you all have this big, pretty, chart here that shows all of the clinics and the hospitals that we're going to be contracting with for this, PCMH movement and what all of them are gonna be receiving. So this is kind of the big reveal. We haven't shown this yet, just the methodology. And this, again, is something that Dan worked on, Wes and Sam worked on, Carol. This has been a big achievement for us, I think.
Yeah, basically it starts with the total amount allocated to this through the district budget, which I think Carol is going to go through.
Which is $9.1 million.
Right, and then we break that down by those categories. Each category is assigned a weight or a rank in terms of how important it is. If it's more important, it gets more points.
And that was something that we went through with Mike Marsh when he was here also, right?
Right, when he was here, we talked about it. So you break that $9.2 million among those components, and then those components are further broken down by organization. So it's a little complicated.
It's really complicated, and it has been a big push from all of Greater Columbia, ACH, I would say, and Mike Marsh and Dan Bazzini.
Yeah, Dan originally came up with the original template, and then we tweaked it several times. As an example, a hospital by itself with no practice could get around 204, we'll say $200,000. If a hospital has two practices, it'd get up to 600,000. One for the hospital, and then one for each practice. And that allocation would be based on the type of measure. Some of them are quarterly, some of them are twice a year, some of them are once a year.
And then I guess the only other difference between the two types of organizations is if you were a hospital, we lump the payments of empanelment, risk stratification, access and continuity, we lump that into hospital care management. So those three payments that you see above for the clinic organizations, we added those together under hospital care management. That would allow a hospital provider to hire somebody to manage the care of a person that's transitioning out of the hospital, or they could use it for community health workers. It's really a discretionary fund, but we wanted to make the payment amount equal between hospitals and clinics, but because of the uniqueness of hospitals not doing those three areas, we lumped it under care management.
Right. Hospitals don't impanel patients. Primary care practices do. For example.
You know.
Again, it's a little complicated. We can probably set up a session where we walk through it in more detail.
Absolutely. If anybody has any questions, I want to talk about this further, especially, I'm sure we'll be having one-on-one conversations with individual providers once we actually get down to reviewing the contract with them and getting it signed.
I have, struggling with the term revenue sharing, and it might just be because in my world that means something totally different, but I don't know if that's true or not.
It's what we call the model.
Okay.
It's just the name of the model.
Okay.
It's that DSRIP. Again, Carol's probably going to talk
But
about
it's really
it.
just sharing in the DSRIP
Yeah.
allocated money, right?
Yeah.
There's no like a shared savings revenue. Okay.
Right, it's based on the provider achievement tied to their contract for all these different areas. We just call it the revenue
We
sharing.
could just call it revenue, the revenue model.
Yeah.
This is how they're getting paid.
Yeah.
Yeah, it's not like a gain sharing model or something like, well, it's, anyway.
So on the, looking at this one, the model, is it possible for organizations to get partial points?
Yeah.
Or is it all in one? It is. Okay.
It is. It is possible. And so that's one of the things that Dan did is he did make a spreadsheet that can be dynamic. So if they don't make the 3 points for the bi-directional integration, if we change that to 2, it reallocates all those funds across,
Great.
which
Okay.
is amazing. I was very
Just don't mess
impressed.
it up.
Yeah. No, we're locking all down, all the cells.
Yeah.
Calculating the formula.
So, Dan, are you on the line?
Yes, I am.
Did you want to defend yourself or
Take some credit.
Just one correction, on what's on the screen right now, if it's the performance column that you would change if let's say in the first quarter of next year, a partner did not achieve all of what was in the milestone, then you would reduce their performance level accordingly. The point system, which is the other column, was set by the board, was in effect the prioritization of the budget. And if you change that number, it will change everything else. So I just want to make the point that on these individual rows, if you're tracking performance and want to recalculate based on actual performance, it's the performance column that you would use. The other comment I wanted to make was revenue. The reason I have been advocating the use of the term revenue sharing, because most people involved in this project are used to receiving either payments for service contracts or grants, and the whole DSRIP model is very, very different from that. You have to do the work first, and in effect, then you earn the ACH earns revenue, and then that revenue is allocated out to partners based on their performance. That's sort of the rubric that is being used for DSRIP, and so rather than calling it something that might confuse it with grant monies, I use the term revenue sharing.
That makes sense. Thank you. I have a couple of questions, and maybe there is like it would be helpful to have a sub call, because I imagine actually every MCO would want to hear a little bit more about how this will work, because if there's ways that we can capitalize and support, I think that's important. But like the way that it's broken out by component for like a primary care provider, does that mean that they're set in the budget for that component? And if so, like some of the FQs already do impanel patients well. They know how to do that. So can they use that for something else, or how does that? Okay.
Yes.
I just wanted to make sure.
In fact, Sam has written, I think it's a 42-page toolkit that accompanies this, so that you can cross-track every single one of these line items with a complete explanation of how you earn the funding. So we didn't include that today because it's a lot to read.
Yeah.
But it will become a part of the practice transformation implementation work plan, so that people can be guided by something more than these numbers. Although the summary sheet does a pretty good job. This is the summary sheet. Does a pretty good job of explaining what all of these different use categories are, Caitlin.
Okay.
But you're right. If the provider has already, in fact, earned some funding because they do empowerment, then they would automatically get that funding and they could use it for something else.
So the reason why there's so many categories here is because they roll up to what we call the core concepts of the patient-centered medical home under the Safety Net Medical Home Initiative. They have implementation guides. There's actually, I think, 8 core guides and then 3 supplemental guides. So, you know, in some way we had to stratify how do we score individuals for meeting each one of those implementation guides. So I'm not quite sure about budget, but all those other categories that you see under the category column relate to those implementation guides of the Safety Net Medical Home Initiative, which is tied to PCMH.
This is Dan again. Just as the ACH earns revenue from the Medicaid Transformation Project, and once that money is earned, it's discretionary. It's the ACH's to use as they see fit. Just as that's the case at the ACH level, the same is true at the partner level. Once a partner does the work, reports on it, and is given credit for achieving certain milestones, then they earn this revenue. The revenue is projected here at the maximum level. They earn whatever revenue they earn, and once they receive it, it's theirs. It's not earmarked for any particular thing. It is revenue like any other discretionary revenue. And so the principle applies to the partner just as it applies to the ACH.
Thank you, Dan.
Thank you, Dan.
Is there something that like the practice transformation work group did or looked at?
Yes.
Or
The
other?
practice transformation work group looked at everything except for the one with the name. And this is the first time anybody's seen the name.
Yeah, this is the first reveal.
Okay, because and I'm not on that work group, so I can get filled in, but I would be curious to hear with some of these components, what like Darlene and Ed think about them. 'Cause, like, empanelment is not necessarily something that could even happen in a BHA, or if it does, it's different than the way that PCMH would define it. And usually has to do a lot with your attribution or your assignment, and that's not how PH works. So I just
So again, there's an implementation guide specifically tied
to BH providers.
No, to empanelment, the concept of empanelment. So for BH providers, if they have primary care within their practice that's empaneling patients, then this would apply to them.
Okay, but if that, so like, I think about comprehensive, YNHS is in their facilities, but technically they're YNHS patients. They would be comprehensive panel.
They're YNHS.
Yeah. So
This doesn't apply to BH, because it's a behavioral health provider.
Not for straight behavioral health.
No, but there are, comprehensive is integrating, and I think Catholic Church is also integrating, so you guys do empanel patients, right? So the whole idea is integration.
We don't now.
But that's one thing that you do.
But only if you have an independent primary care provider in your facility, like, they would, I'm just thinking it from even a payment standpoint, like, we would pay YNHS for the services that they provide on site at comprehensive. And it wouldn't, and maybe YNHS and comprehensive have an agreement about sharing in the savings of improvement on that quality, but that the empaneled population is with the primary care provider. So I
just like it is now.
Yeah.
But those are conversations that are happening.
Happening, great.
Yeah.
It's a good point.
So Wes, if there's a question, what Spriggers earned is really going to be important to the CPAs, to the financial statements. Are you the person that we, who would own the definition of earned income?
So I assume it's being scored by for a lot of this is the practice transformation navigators who go out into the practices, because they're the ones working with the practices to do the initial assessments and then achievement across these contract deliverables. They're supporting that.
You were asking about the accounting.
Yes, just who can confirm
accounting question?
Well, so what's the question about earned income?
Right, no, the question is
When they're complete.
upon receipt, is the work complete? So it's booked as income. Is it to offset costs, or is it other operating income. I mean, and every one of the people receiving this is gonna have the same series
We're
of
with
questions.
deliverables, right?
Yeah.
It'd be
Deliverables.
It's a contract
Well,
deliverable.
So, and I frankly don't think people who can answer that. I think it needs to be somebody sitting down and just getting that straight one time, and then we'll know. So, but it's a pretty technical question. So,
So when is the money earned
mhm,
for the standpoint of accounting?
right. And
I
I
get
think
it.
we just need a person to talk to about that. Because once, like I said, once the question's answered, I think it's answered for everybody.
I'm expecting that will be in our contract.
Yeah, if you're on a
I
cash
think that is
basis.
more like a deliverable.
No, it's, yeah, okay.
And the information that you talked about that Sam's developed will be disseminated. When?
No, I'm asking because I'm
Along with the contract.
Yeah. So
the
that's
accounting.
part of the next exhibit, the PCAW transformation implementation plan. It goes into a little more about the deliverables and, this is the beginning part of it. The second piece is the big toolkit that has a lot more detail, which Jen is nodding her head. It's a huge document, 45 pages.
Big one.
Yeah, so we didn't print it all for you, but it will be, it's part of the PCAW, so it will be part of this contract, and it goes into great detail about the milestones and what you have to specifically do to earn the money that is in the contract.
Yeah.
And that other spreadsheet kind of has the terms and conditions.
Yes, and so then exhibit C is this one that, Carl already mentioned, has the milestones and the quarters and when they're paid, and then there's a little description of the terms and conditions in regard to what you have to do to earn, to complete those milestones, but there is a lot more information in the toolkit that will be disseminated with the contract to the provider.
Great.
I think, Julie, ultimately it would be Sam that would determine whether or not the provider has earned that amount based on her review of the practice transformation implementation work plan.
I would agree. So we added a signature line on the practice transformation work plan for Sam. She's the one that will work with the navigators to make sure that the milestones have been met. And then, well, so we did the similar thing on the BHO contract. Once I received this signed from Sam and I received confirmation from Sam and Jenna and Martine that the deliverable had been met, then I authorized it. That was kind of our check and balance on that. So it wasn't just me going in the portal and saying, yeah, we're gonna pay these people. I had to have confirmation that they had met the deliverable. We're gonna do similar with this contract, even though it's much more detailed, obviously, the quarters and all these deliverables are a lot more intense. So anyway, so that's the last exhibit, I believe, exhibit C. So exhibit C, you guys have all seen, it's, the non-allowable expenditures, which we kind of follow the federal guidelines of. Obviously, I don't want you guys.
Show us what that looks like.
Spending, you don't have it.
I
It's
have it in
in
mind,
the
I just
contract.
wanna need, okay.
Exhibit C in the contract.
It's in the contract.
Yeah, it's
not part
actually
of it.
in the contract, yeah. It's been in all of our contracts, it's just, we don't want you going out and spending money on alcohol or paying your debtors or, just basic federal guidelines, nothing shocking. And then, that's pretty much it, that's the contract.
Do we need a
We
motion
need
on
a
this?
motion, yes.
Okay, so, on all three of the exhibits.
Yeah.
A, B, and
There's,
C.
yeah,
Are the new
there's
exhibits.
4, A, B, C, and D.
A, B, C, A, okay.
Yeah.
So A, B, C, and D would include the formula,
Yes, that's A.
D, and then the
Nope.
multicolored one?
Nope.
The other one, the individual.
So let's make sure that everybody knows which ones we're approving.
So
Or we're
A
reviewing.
is this one.
Okay, so that's the formula.
That's an example for
Example
hospitals.
of, yeah.
Okay.
And then B is the PCAW.
It's the one that says practice
Yeah.
transformation
Yeah.
information
I
sample.
told you they didn't write on that one. And then C is the non-allowable expenses, which is a page in the contract.
Yeah.
And then D is the milestones with the quarterly.
The schedule.
The schedule.
So is there a motion to approve those?
I so moved.
Who was that, Darlene? Is there a second?
A second.
Second by Sandra. Is there any further discussion?
I just have a question, and maybe it's not, I don't think it's relevant quite to the vote, but more of the process is how, so I thought I heard you say that Sam, Martine, and Jenna evaluate, and so then their payment comes, but is there value in having the practice transformation work group doing some of that review of the evaluation only to hold providers accountable to what they're saying to learn from each other? Not holding them like they wouldn't be telling the truth, but to explain like how they achieved certain things, and it checks, it has another sort of eye on the improvement processes that are happening in the region, because a lot of things need to be sort of standardized as well as individualized. Does that make any sense?
I mean, they could review at a high level how all practices are performing as a group as we go from quarter to quarter, as you see across the schedule.
Getting made, their data.
I think it'd
Yeah.
be great to discuss and share their learnings, absolutely, but wouldn't want them to be any part of the approval, whether or not they are.
Get paid.
Yeah.
I think it'd be a good opportunity for sharing learning.
Yeah.
Well, once we get their, their data and their metrics and stuff like that, that could be something that we can present to the practice group.
I think we need to do something, because like even in the small discussion we had here about empanelment, like if there's a possibility that BH providers may never be able to get that payment.
Do you want to talk about that, Dennis?
Yeah, please.
Yeah. So empanelment is actually a thing for behavioral health providers, and it's a component on the MEHAP. So not on the old MEHAP, but the MEHAP Plus, there's a specific question that ties it to empanelment, because when we do our PTIWs for the organizations that have primary care and behavioral health, they get 2 scores. Each measures the same. So empanelment is something that behavioral health providers can do, and it specifically asks for high-risk vulnerable populations. Do you track those? So it is a thing for them.
So it's more about like it's almost like a registry that they're
Yes.
using. It's less about like this is your kind of attributed population that you're
Yes.
tracking. Okay.
Not as much so
That's-
in the MCO sense of the word
Yes.
empanelment, but
Thank
just like
you.
tracking.
That's
That makes
great.
sense?
Yes.
Okay.
Thank you.
We
We
use
have to
the same
research.
words for so many things.
I know that's the problem. It's always like
It's
shared
confusing.
learning.
Good
Yeah.
clarification. Any further discussion? If not, all in favor?
Aye.
Aye.
Unison. Anyone opposed? Is anyone abstaining?
I did not hear from all.
Okay, good discussion.
Yay!
Okay, action item. ACES campaign update.
All right.
Isn't that what we did?
I thought we did the contract.
Do we still need to do the resolution?
Different bullet, this is a couple. I don't really remember.
I thought that was all part, so,
It was part of it.
so
Was
Becky,
it part of it? Okay.
it was that, Becky,
That was that.
did that
telephone
include the
one.
revenue sharing model, what we just discussed?
Is this included with all of that?
That's not,
Is that
we're
separate?
not approving this, we approved the process.
process.
Yes, you guys
Okay.
already approved the process.
So do we need to discuss the revenue sharing model?
No.
No.
We already have.
I think we've already
You're
reviewed
done
those.
with me, aren't you?
I was just, I'm pushing myself, okay?
Okay, Ruben, ACES.
All right, I think some of you are familiar with this document. This is the framework I handed out to those of you who participated in the conference call with Primera and Camper Collective. So, most of you probably haven't seen this. What this is the framework for NACE's campaign in our GCACH region, and we presented it to Primera and Camper Collective. And I'll explain a little bit what Primera was doing. And Camper Collective, they're a consultant that's assisting Primera spend $330 million pretty much. Primera got some tax money back, $330 million, and they want to reinvest it back. They're going to reinvest it in four categories. One, their employees. Two, their clients. Three, community impact, which ACES is part of that community impact. And four, rural health. So they contacted us and they flew into Pullman. They met with the Pullman hospital people there and the local health improvement network over there. And we met with them in Pomeroy and we toured with them pretty much from Pomeroy to Dayton, then from Dayton to Toppenish, from Toppenish we met with the Yakima tribe there and with Astria. And then from there to Yakima, we met with a comprehensive, we met with farmers and CHW, I always mess up those acronyms, but you know what I'm talking about, right?
Yeah.
So they were not listening tour pretty much to see what needs there are out there, and their main focus really is rural communities. But we kind of, we also talked about us wanting a little piece of their community impact funds as well. we were pretty obvious about that. So they're pretty much concluded their listening tour. They're going to invest these funds in Alaska and Washington. So early next year, they're going to pretty much release the details on how communities can apply for those funds. So they certainly seemed impressed by what they heard in the different communities. Carol, do you want to say anything before I get into my campaign? No? All right. So and if you remember some time ago, I floated the idea of putting together such a campaign, which it would be a media campaign, bringing awareness to the public on the effects of ACEs. So, and not only just bringing awareness to them, but also funding existing resiliency programs to make sure that they increase capacity in the work they do. Because I went to the San Francisco ACES conference there where Dr. Felitti, one of the principal researchers of the ACES research, spoke, and Dr. Nadine Burke-Harris. She's an early adopter of the ACES study, and she implemented that in her practice. She's a pediatrician. So it is, the country is pretty much over those of us who are in or around healthcare and people in education, everybody knows about ACEs and the effect of ACEs. Okay, so there's a lot of awareness out there among social workers, community health workers, so everybody pretty much knows about it, the importance of them. But the public is not aware of what ACEs are and the effects they have on people's health. So what this is a proposal, an idea. This is just a framework. It's pretty general. It's pretty fluid. The thoughts here are brainstorming still. They're just ideas, and certainly they're likely to be added to or changed. But then the idea is to go a step beyond. Start bringing awareness to the public of the effects of ACEs and start funding this resiliency building program. So I'll go over some of the general ideas, like I said here, that the public towards the bottom there, public awareness, do it in the most the languages that are spoken within our regions. And I just brainstormed some of the languages that are probably they have the largest numbers of speakers within our region. Like you see there, the Yakima tribe, the Yakima language, we're going to be working with the Yakima Nation separately, but my thinking is that to do something in Yakima as well, media, print, and that kind of stuff. But certainly, that's going to be in consultation with the Yakima tribe. They might end up saying, yeah, no, we don't want that, but that's just a thought to include the Yakima language in this campaign. And as far as the mediums, radio, TV, social media, print, maybe even billboards as well. And we're also thinking to sponsor programs in radio or TV, to have someone maybe once a week go to that program, radio or TV, to talk about ACEs, to maybe have call-ins to have a discussion about ACEs and the impact and also what resiliency programs there are available for people out there. So among programs, so resiliency, and they also refer people to resources where they can get help for any particular situation. Also, once we have our campaign going pretty much, and in this ACES campaign is somewhat known within our communities, then bring some high-profile speakers. Maybe Dr. Vincent Felitti, maybe Dr. Burke Harris. Daryl Tonema, I heard him speak in Toppenish at an ACES conference there, and he's an excellent speaker. Very, very engaging and very, very funny as well. There's a comedian, Gabriel Fluffy Iglesias. Some of you might be familiar. He's going to be here in the Toyota Center. He's going to be here in March. So I reached out to his staff. I haven't heard back, but kind of looking into if we can do something. When he's here, maybe he can record something for us to run with. So that's these are ideas. Dr. Cesar Lozano, he's a Spanish radio personality. He's kind of like the Phil of radio. So he's another possibility. Have these speakers or whoever we end up bringing in, have them come to the Toyota Center, the Yakima Sundom, or maybe a large high school auditorium, and invite Medicaid consumers. Hand out the tickets, free for Medicaid consumers. Recruit CBOs, recruit health centers to promote this, to give tickets to consumers, invite healthcare workers, invite educators, government officials to come and listen to the speakers. Because by then, like I said, your average public is going to, we're already going to know something about ACES and what they do, and maybe they even will know these names by that time. Daycare providers, I forgot to mention them as well. And then as far as resiliency programs that we can fund and scale up, and these are just ideas that came to my mind of some programs that I know of, but there can be many more here. I'm going to put together a crosswalk of as many resiliency programs that I find in the different communities, and to maybe organize them by category, whether they're school-based, community-based, whether they're targeting adults, whether they're targeting young people, whether they're targeting refugees, for example, and then put it together and at a later time bring it to you, with a budget, with attached cost to everything, and for your approval. So there's more stuff here. Also, it would include training for physicians and clinical. I skipped to the last page already, pretty much, second to last page. So we include training for physicians in trauma-informed care, nurse training, mental health first aid, telepsych services, that kind of stuff. Community sponsorships. We were just talking about community sponsorships. Community events. Come up with a Mother's Day celebration, Dia del Niño, Day of Children's Day, April 30th. Come up with a resiliency day. Also reach out to employers. Large employers here, Lamb Weston, Conagra. It's not IBP anymore, right? What is it, Tyson? Yeah, it's Tyson. So reach out to large employers here and get them involved in trauma-informed work sites. Get them involved in maybe in some campaigns on letting their employees go to parent-teacher conferences, paid parent-teacher conferences, to let their employees take their children to doctor's appointments, paid or something to that effect. And I know this is a large stack, job. I wouldn't be doing that by myself. I would probably be thinking of putting together a focus group or a work group perhaps that would help me put this together. Certainly the radio spots, the TV spots, I don't have those expertise. We would have to hire somebody that can craft the message. And again, this focus group can probably help us pretty much decide what the focus is and that what the impact is that we want to make, and then the experts can craft it so that the message that we want for trade comes through. Reach out to law enforcement, do some trauma-informed work there with them as well. So I'm not going to go through every bullet point here. You can read that yourself. But pretty much creating a trauma-informed community. Bring up that awareness and build up, scale up existing resiliency programs. And a lot of people are at this point to where the healthcare workers and educators are aware of ACEs. Very few communities are actually taking the next step to start doing something about it. Scotland is actually, they're aiming to become the first trauma-informed country. I know Tallahassee, Florida, the city, they're doing a citywide effort. They're working on a citywide effort to become a trauma-informed city. So this is something that we can, work on. And like I said, this is just the framework. This is just a general framework that can definitely be modified as we put it together.
I think that this might be something that can be worked through. Carol, you can correct me here with the communications work group.
Mm-hmm.
That could be part of the process that they work with Ruben on this as well.
Just one thought on this, Ruben. There's a lot in there, so I think it's big, and we'll need to find some focus on it. But coming out of the Medicaid transformation workshop planning training day, John Powell talked about belonging. What if we don't maybe educate so much, but we create opportunities for belonging instead, and take that approach to some of the work we do? Just food for thought concept as you finish fleshing this out. Instead of telling people about the ACEs that they have, why don't we find some ways for them to feel belonging and enhance some of the groups? I like those concepts, like enhancing the, coffee with the cups, those things where people can feel like they have a belonging, and enhancing those groups.
Connecting the networks, Dr. Powell, he talked about those networks. Right?
Yeah, one of the biggest issues with people not feeling like they belong, and that's to me, it's more solution-based versus telling people about a problem that they have, because what we have happens, and that we all comes to our mind, is like, I would just taught you all about these ACEs, and now we've opened up a whole floodgate. We've opened up some floodgates, but like, why don't we just start with the solution a solution, not the solution. There's no the solution, but a solution, and come up with some of those ideas, incorporate that into this process as well.
Well, the reason I'm taking that approach is because Dr. Felitti, in his research, he mentioned that with the 17,000 people that I don't have to describe the population he worked with, right? Because all of you probably know the demographics of that 17,000 group. He mentioned several measures that improved just on these people, just by them becoming aware of what ACEs was doing to them, or what ACEs did to them. Lower A1Cs, less ED visits, a drop in ED visits, a drop in a doctor's office visits as well. So there's a lot of benefits to just being aware. We certainly need to craft it so that it's not, hey, the reason you're screwed up is because of this.
Focus on the resiliency and the resources.
Tell your mother.
I think there is, some benefit to making people more aware. I also just think that when we look at resources now, and I look at the providers that I know of, everyone is, some of our options for expanding access to resources, it's not so simple. It's, we need to build a new building, we need to expand the clinic, and they're big, high capital dollars that this money doesn't help providers address. So if we could, in addition to, as part of this plan, find some ways where we are maybe not focusing on the educating of this is, these are your ACEs, and this is what this is, and this is how you got there, but this is how we address it instead.
Hey, this is Megan on the phone, and I have to echo what Sandra is saying, because a lot of our community, we're moving to this point here in Walla Walla where we're focusing on solutions, and a great evidence-based option or model of that is sources of strength, and that's empowering youth in our communities, and that's really where we're going to start to move the needle, is on these solutions. So thanks for bringing that up, Sandra.
And I just think it ties, sorry, Rhonda. I just think it ties in
And
line with,
just-
I know, I think Walla Walla is maybe looking at Blue Zone, and Yakima has looked at kind of the Blue Zone project model, and I think that incorporates some of the initiatives that some of the communities already have going on. And so it would tie in nice to some of the communities that are already struggling.
So let me just say, I think this is a really good discussion that warrants more discussion, that maybe we could put on the next agenda, because I think this really is talking about what our vision is on how we as a region move forward in solution-based problems. And so if we could, I'd like to maybe put this on the next agenda, because we have 15 minutes left. But I think this really sets us up to talk about how we're going to move forward with solutions in our communities, both in terms of from ACES, resilience, and I think you're spot on, Sandra, in terms of some of the things we learned at the Learning Collaborative. I think they all sort of dovetail in together, but I think we've come through, we're sort of going through the tunnel, and it's like, are we ready to come out the other end with some solutions? So really good ideas, really great ideas, Ruben, that you've outlined. And so I think we should maybe try to spend some time at the front end of the agenda next time, so that we can dedicate some discussion time to it. So people could think about that, and we'll put it on earlier in the agenda so that we can spend some time there. So if we can, let's go on to the 2019 budget, knowing that we have limited time with the rest of today.
Okay, so with limited time, again, this is just a discussion item. Carol and I have been pouring through, well, I have been learning about how this budget for 2018 came about. First of all, that was a big education for me. I went through our financials for the whole year and tried to make it all make sense for me, so that Carol and I could work together to move forward for 2019 and maybe make some different decisions about what we do with our money. So this first one is the design fund, and it has a column for what we budgeted for 2018, and then the thoughts that Carol and I have had about how to budget for 2019. I think probably the biggest thing that we did was we took the salaries for our staff and put them back into the district funding, which when I was going through the financials for last year, I learned that's how this year started, was with the money, Carol, and the district funding. So we're just kind of going back to that model. Everything else, we took a lot of the IT budget and put it back through the district funding. Other than that, I don't think we made too many big changes, Carol, unless you have something.
No, so the reason that the design funding had the $216,000 allocated to staff salaries is because we didn't have design money until May of last year, so we had to use design funding to pay salaries. But in the fund flow model, there's a small administrative fee against the district funding to pay for the work that we do. And like Becky said, really very similar categories to last year. Trying to figure out, in terms of administration and project management, how we can be a little bit more efficient with some of our funds. So you can see that we had to up some of the legal and professional fees because now we're getting into contracting and auditing and those kinds of things. But we've expended most of the money that we need to for office expenses like furniture and things like that. And again, the health systems and community capacity building, that will be coming out of the district fund. There's a category for that. We did put in, though, $40,000 that we didn't use this year for grant writing for next year, anticipating that if we can get some of the Camber money, there's a group health foundation, just to be prepared, because I think that there's opportunities for that, to try to go after some larger grants that would pay for these regional campaigns that we're talking about.
Another new category that I think is important to note is the professional development. Carol thought it would be, our staff is growing and we need to continue everyone's professional development in their field. So we added $40,000 for that, which allocated out to 3,500 staff. That's under the administration and project management.
Okay, under administration and project management.
Yes.
Okay. Just trying to find the line.
Sorry. I should look at the screen.
And again, this is just a discussion. We'll bring back the budget to vote on next month, but if you had any concerns or comments or questions, I'd be certainly happy to take those at this time.
You have specific requirements based on which fund you're talking about, on how much you can spend on different things?
No, there's no stipulation.
Because that's one of the things that often moves stuff around sometimes. You can pay for this out of this, but you can't pay for it out of that. Okay.
No, we don't have any stipulations on that. So I'm going to switch to the district. We'll go over that really quick. So there's two columns for 2019, and I just want to explain the reason behind that is we received the $9.1 million this month that we just discussed. We're allocating all of that to the practice transformation contract. And then in May-ish, we're anticipating, we discussed another $10 million for completing the next SAR. I'm sorry, it's the acronym. I was trying not to.
Semi-annual report.
No report. So that's why we made two columns. We've allocated the 9.1, like I just said already. The 10 million, though, we're not really sure what we're going to do with all that money. So that's one of the discussion items we'd like everyone in this group to kind of think about is help us with that. If anybody has any thoughts or ideas.
Give me a car.
Open. Yeah, I know. I thought Disneyland, but
retreat. 2 weeks.
So, anyways, that's kind of a real quick and dirty on what Carol and I have been working on for the last couple of months, kind of putting something together and getting our departments together to figure out what their needs are going to be for next year. Anticipated needs, of course, because we have no idea, but we'll have some ideas.
I do have a question then. So we as a board did vote on your health care and getting all that stuff done for the ACH and the staff. And I'm wondering if there's anywhere in that piece that you guys need more support. So maybe some of that money can be allocated for those parts that aren't being covered with your health care. I'm just concerned about you guys, and I want you guys to be healthy and be able to come to work and your families be taken care of. And
that's something to consider because right now we offer 100% payment for the employee, but nothing for the family.
Right. So that's what my concerns were last time. What were we going to do with the new babies coming on board, and what would that look like? You know, so
that can be something that we talk about.
Just saying.
I'm not having any babies.
Somebody will. It's inevitable. Okay.
You know which chair does.
Yeah.
Laura's like not in.
There's one coming. I can guarantee you. By spring of next year, somebody's going to be talking about winter.
And there's only two possibilities. In that
Okay.
conversation that we typically have the benefits committee or the group that looks at that. So
I'm just saying.
appreciate your concern. I think we all have.
I love our ACH.
And staff that want to know that.
So I'll just add a couple of things that, so Becky talked about the 9.16 million that the board allocated for provider payments, and then you move down the column. And then actually this was just, we were subtracting out of the total allocation that we received, which was about $11.3 million. We carved out the staff salaries at the bottom, so you can see for administration and project management, that's about $1.2 million for staff salaries. So that left us with a little bit left over. We put some of that into workforce and training and scholarships, about $86,000. But again, when we come back, when we understand what our next allocation is, and we actually have a bunch of funding left over this year that was in that category that we haven't used up. And then we already had decided at the last board meeting that we would take the contingency reserve and allocate the additional $667,000 to the community health fund. So that's why you see that as kind of a zeroed out item in that second column under 2018. And then we fully funded this ACES campaign for 2 years. So this year it was for 300. So we put another 144,000 allocated some of that to the ACES campaign. So that's $600,000 for the ACES campaign. And then we put the reserve back in there. And I think that there will be another really, really important discussion around the Behavioral Health Integration Fund, that $6.4 million, which is the second wave of funding. I'd really like for the board to consider the best use of that fund, whether it's providing funding to create opioid resource networks or somehow beef up the network of providers that we have to address behavioral health issues. We're hoping that our providers can get, enough funding that they're ready for integrated managed care. But I think we need to be really thoughtful about how that next $6 million is going to be allocated. And North Sound, for example, took all of the IMC funding and they are distributing it not just to the behavioral health providers that were contracted under the BHO, but they're also expanding some of that funding to go out into the community to provide other funding for other mental health agencies that were not able to get contracts with the BHO. So
actually, we started to have that conversation in the last couple of months about, what is, if we wanted to try to expand the capacity, what other behavioral health providers are out there that are not part of our system?
Right.
How hard would that be to find out, or do we have that in our inventory? If we did an inventory, it's been a year. Is that information in our inventory?
I think we could find that out pretty easily.
That might be good information.
Because there are only
GCACH
7
can tell you who is licensed in the area. Yeah. But that might be, at least that would at least be good information to have.
Okay.
Yeah. So I was asking Caitlin and Kat about, there are other providers that are contracted with the MCOs that are not the BHO providers. So I asked them if they could get us a list. That way we can see about including them in the incentive dollars.
Are those licensed providers?
They are, but I will say a lot of them are independent practicing providers. Or part of it is there is no access to care barrier anymore. So mental health providers at any primary care agency can provide any level of mental health services that their license allows.
Right.
So some of them are more attached to like hospitals even, or other facilities are not necessarily, I'm still fine giving you our list, but they may not be entities that need incentive dollars. They may be attached to entities that are already a part of this, or they're independent and it doesn't, like they might be one psychiatrist working, which is probably too high of a thing, but working on their own in an area, but we can still give you the list.
Okay.
For me.
Well, one of, and I don't know how this relates, but I know that in our area there are very, very few, if any, behavioral health providers that do, for example, incapacity exams for Medicaid clients, and that's a problem. So, and that's just one example that I happen to know about. So, it just, what is the need? How could we expand it? This might be an opportunity.
And it might be something we want to evaluate again after 6 months, because we'll have at least some encounters to look at. Not a whole lot, but we might be able to pinpoint where those kinds of services are popping up more now, because it was not restricted, but just the way that the DHO gave out money before is different.
Yeah.
Okay, so can we keep going? All right. You get to, you're the last on the agenda.
I am the closing act.
Update on the portal.
Okay.
Closing act.
Closing act. So last time, the board looked at the SBAR that was relating to the CSI Solutions portal. Without going through what that is, The board approved it contingent upon a provider demonstration. One was set up on November 7th. Individuals from YNHS, Astria, and Tri-Cities Community Health, as well as GCACH staff members and people from CSI were part of that demonstration. There were also invitations to Palouse, Molina, and Stephanie Macias, who didn't show up from Astria. So the demonstration went through. In this document here, some questions arose, such as how much time does it take to enter the data? Can we link the portal to an EHR so data is downloaded? What's the long-term sustainability of the portal? We tried to respond to some of those questions, and I think that we responded to most of those. I'm not quite sure what else to say about that. We did come up with some next steps. Some of the next steps include review back here by the board to show that that had been completed. One other action item that was talked about was to create sort of a beta test or a test environment. So the portal would be set up so people who are part of that call or could have been part of that call could test the portal out in a way just to see how does it work with some dummy data. How quick is it to upload information into the web-based forms or to use some of the directories that are on the front page, the landing page of the portal. So we hope to get that set up once the contract has been signed. We also have an internal action item. The portal has actually a bunch of pieces to it. We have to assign responsibility for staff members who will be completing which piece of the portal.
So the feedback that I got, actually, it feels a little backwards to me that we would sign a contract before we've had the demo and the staff and the players are.
We haven't signed the contract.
Okay, this to me says that you're moving forward with signing the contract before we've had the demo and people feel comfortable. Because I know my staff person that was involved, and I think the staff person from Tri-Cities Community Health wasn't really sold on this, that they didn't think it was going to be terribly useful.
The portal?
Mm-hmm.
Well,
so are you planning to sign the contract before the demo happens and people get to do it?
Well, I thought the demo was conducted.
That was a PowerPoint presentation,
Yeah.
and what we had talked about was letting people actually try to use it.
Play school.
I don't know if they have a test environment set up like that. For them to do our beta, they would have to do a lot of work to get it set up for one that's specific to Greater Columbia. So all the ones that they have now are actual portals of other organizations.
Yeah, and I may have misunderstood, but what the report back to me was is that you were actually lobbying for them to set up sort of a sandbox for them to be able to do that, and that you were pushing for that, and that they had agreed to do that.
What I remember about that discussion during that meeting was that Puneet offered to let them play in one of the other, what?
Spokane,
Yeah,
one of the others.
One of the other organizations.
And that Wes thought that wasn't a good idea. He'd rather have them set up something that would look more like what we were hoping for, and that they were going to try to do that. That's exactly what I was told.
Okay. Well, we can try to set it up again where they go in there and play with someone else's live portal. I just don't want them to put in data that's going to affect the performance of the organization that actually owns that portal. So I can ask them again to see if we can set up something that relates to one of the other ACHs. It's not Spokane. It's Olympic, North Sound, and North Central are the other three ACHs that have contracts with CSI.
The other piece that, again, on the information I got back is when they did the demo for us a couple months ago at the Leadership Council, Rob had said that, because some of us were concerned about dual entry, between our own systems, and he said that there would be, we would be able to have an interface, and that on the demo that you guys did last week, somebody said there wouldn't be an interface because that would be time consuming and costly. So it would require an export and then us to go back in and enter.
So Rob's work is different from this. So Rob's work
Whoever was doing the presentation is what came back. So question is
about the
there
discussion
going to
of the
be an
interface between the organization's medical records
Oh.
systems that currently have it, how we're not,
So there's not
how
that whole-
you said we weren't doing that interface.
Okay, so the way that data can be loaded into the, if I'm understanding you, Rhonda, and please correct me if I'm not. So you're talking about the uploading of data into the portal?
The concern was organizations don't want to have to do double entry. And at the leadership council, he said, no, you'll be able to do it in your own electronic record, and we'll pull it from it, just like we do with other things. We'll pull it directly from your EHR into the digital common system. And that's what Rob said when we were there.
Okay.
From the demo last week, what my staff person heard, and you were on it, right?
And that's what I heard as well, that we weren't doing that.
Was
No,
that we
there's-
weren't going to do that.
So again, the digital health commons is different than the CSI portal. The CSI portal relates to the milestones that we just looked at under the revenue sharing model. So all those things, there has to be a web-facing tool where organizations, or it may be the practice transformation navigators, who go in and help the organizations upload the data to show that they've met the contract deliverables. So that's what the CSI portal is going to be doing. There'll be a web-based tool to just go in there and say, okay, under empanelment, section A, I did or did not, or I partially completed that particular contract milestone.
Okay, so maybe I am confused with.
That's okay. It's okay.
Are we talking about two different systems?
Yes.
Yeah.
The Health Commons is a different system for KIDA tasks than the CSI portal. The CSI portal provides a landing page for organizations to go into directories that relate to specific programmatic areas. There may be pieces in there that relate to learning collaboratives. There may be pieces in there that relate to Ruben's work, disseminating through RSS feeds, others.
So this is what Rob showed us last month? Or 2 months ago?
Rob is different. Rob is
CSI is
different.
like a district.
CSI is the one that we saw in the practice transformation work group.
Yeah.
Rob was showing the digital health IT commons.
And that was
which is
at
the
the board
referral.
meeting.
Yeah, Rob's is built around a
So which
specific
did you demo last week?
last month.
CSI.
Last week.
The CSI.
Oh, last week was CSI portal, the landing page, and then the web reporting form.
Rhonda, I think, and correct me if I'm wrong for people on the call, but the last week call on CSI, I think where the confusion is coming from was because there was mention of an HL7 interface in that call and saying like, is this an option? Naturally, that was a question, like, can we just have it just boom, boom from the EMR to CSI? And so where we landed was we would just have it exported, and most of that work, if there wasn't capacity at the organization to do it, Martine and I would upload that information into CSI. So the HL7 was brought up in that conversation, which is, I think, where you're hearing that report back from.
Right. So, for some organizations that are doing reporting strictly around quality metrics like HEDIS, like diabetes, HbA1c, how many patients in the numerator, how many patients in the denominator. Part of that is going to be part of the contract milestones. And you could collect that through what they call an HL7 feed, which joins the EHR with the reporting tool. But it's expensive, it's time consuming, and frankly, if they can just go into a form and type in a number for the numerator and type in a number for the denominator, it saves all that time and effort. So there are some reporting metrics that would tie to an HL7 feed. However, most of those milestones don't tie into the EHR. So the HL7 feed wouldn't be able to collect that information anyway, because it's around the completion of project work that relates to patient-centered medical home. So the simplest solution would simply to be would be to have this web form that's part of the portal. There'd be the landing page part of the portal, and then the web form part of the portal where the provider would enter in that information to again show that they met those contract milestones. Is that still confusing?
Maybe.
Yeah.
I'll sort through it.
So that's why reporting was worth as much as it was on
Right.
the revenue sharing model, is because we know that it's going to take time for our providers to provide us with that information. But I think it's worth $43,000 at the end of the year to do all that reporting, because that's how we get our money, honestly, is by reporting on our providers' deliverables.
So just put money in so that the providers will have resources to be able to do that.
Yeah.
Just to clarify what Carol was saying, doing that reporting in the background will take some time and effort on the part of the practice. To enter the information into the portal itself will be very easy. It should be a relatively easy, straightforward process. And again, the practice transformation navigators will be going out to the provider organizations to help them upload that data. So that part of it should be pretty straightforward. Does that make sense?
Yeah, it's 48,000, it's almost 50,000, so
Okay.
it's quite a lot of money.
Yeah.
I guess I'm concerned if people were underwhelmed, did they really understand what they were supposed to be evaluating if that's the report back? And then that
Rena
would
was
mean
there, so you're the only one at this table that.
I mean, I understood the objective, but I can't speak for the other two, and I did ask on the call, like, the amount of time that we thought that our organization would have to spend each quarter or month or whatever, and it Wes ended up saying it'd be about an hour each quarter that you have to go in and fill out this information on the portal. And to me, an hour for a whole quarter does not seem that time intensive to warrant needing a whole interface. You try that would take more time. So you explained it pretty well. But I think there could have still been using that. But
and again, the way the other ACHs have set up their web forms to enter in those metrics, they're aggregating a whole bunch of different metrics that we won't probably be collecting. And Jenna and Martine help me out here. I think we're only going to be collecting like 3.
In the first, at first, yeah, most of the metrics are really kind of narrative. So are you impaneling? That's really a yes, no, but some of them are saying risk stratification or something along those lines. Like, if you don't have it in place, we plan to, or we're putting this kind of stuff in place. So it's really narrative form.
Yeah, it's a lot different than the other thing that we saw, right?
Digital health.
The digital health comments?
Digital health comments.
Yeah, that was completely different.
I can see where that one needs a upload.
Yeah, actually, if you want to know more about the digital health comments, did we forward the video about that? So Rob put together a video with Kittitas, which really took off. So Rob put together a video about Kittitas that shows how that software looks, and it's actually very slick. He actually took an electronic health record and customized it to meet the needs of the individuals in that community around specific use cases that related to behavioral health. It included comprehensive, it included EMS, included primary care, the A team of the Kittitas Community Health Network. A lot of people got together and talked about what's the care pathway and what they were,
That's right, that was the thing that tied everything together.
Right, and so then they brought in the EHR, and pre-managed fits into that as well, and he knows way more about the technical nature of that. That was a very customized approach, and again, I can show you that video that shows what that looks like. But that's different than the CSI portal. I know some of the stuff is confusing. There's even other pieces that we're working on as well that are listed in the group Greater Columbia report that talk about, I keep on wanting to say group health, that talk about the direct secure messaging, pre-manage, and some of the other tools that we're doing as well. So there's a lot of HIT investments that we're making both at the system level and at the provider level.
Okay, thank you for that clarification. So is there any other business for the good of the order? Anybody on the phone? Yeah?
No. Well, over to Caitlin and just see if I know that I'm not the representative on the board, but with respect to the HIT space, so as we were working at PCW on our clinical integration solution, the idea of how all the pieces fit together in a picture, I know there's the narrative in the GCACH report, maybe just thinking about as next phases move forward, how the pieces fit together. And how they can be leveraged by the different providers, and maybe a use case with respect to how the CSI portal, imports the data from Disrupt, how the secure referral, that just may be helpful in clarifying the uses for the tools and how they can support the work that's moving forward within the ACH.
So Lori, did you have something?
Oh, I do not. Thanks.
Okay. Okay. Thank you, everyone. I think we're done. Thank you.
All right.
Thank you. Bye-bye.
Hey.